So Michelle is a senior lecturer, and she's the M-Pharm Deputy Director at the School of Pharmacy and Biomolecular Sciences. She is the RCSI Academic Lead for Patient and Public Involvement in Research and the Site Lead for PPI Ignite. And this is a funded national collaboration across 7 universities that promotes excellence and innovation in PPI. So Michelle's research combines human-centered design and health service research approaches, and she's really committed to improving patient experience and outcomes through her research. She's been working really closely with the Sjögrens Ireland group on a number of research projects and PPI activities. Michelle is a registered pharmacist and has worked in community pharmacy for several years before moving into an academic role.
Thanks, Joan. So, morning, everyone. My name is Michelle, and it is absolutely brilliant to see so many of you here this morning. And hello to everybody who's been in touch saying that they can't make it this morning, but they'd like to be involved through getting the recording afterwards. And it's a real pleasure to speak with the Sjögrens community. As Joan has said, I've been working very closely with Sjögrens Ireland and Joan and Sjögrens Research Ireland on patient and public involvement. And so what I'd like to do is take a couple of minutes of your time to encourage you to think about whether now or in the future, you know, kind of depending on how you're feeling and what's going on, how you might get involved more with the, I suppose, the research side of things, but also with some of the initiatives we have going on in RCSI, because we're always delighted to have you know, people coming in and attending, you know, kind of our sessions and helping us understand more about what we should be spending our time on. So as Joan mentioned, I'm in charge at RCSI of, as well as teaching pharmacy students about a thing called patient and public involvement in research. And that's really how I got to know Grainne and Deirdre and Monica and Eileen through working together on trying to figure out what are the challenges that are affecting people, and you know, what should we prioritize trying to spend our time and limited funding on. So what we do is work together in a partnership to try to identify what are the challenges that we can try to put our heads together and address, and make sure that the time that we're spending doing research is going to hopefully improve things that matter to people who are living with Sjögrens. So we have been collaborating very closely on a number of projects, and you'll hear a little bit about them from Grainne and Deirdre. But what I would say is please do keep an eye out for messages through Sjögrens Ireland or from us directly. We are always looking for people's input, because as much as I can tell you about research methods, I cannot tell you what it's like to live with Sjögrens. And that's, you know, that expertise and that knowledge is absolutely critical to us to make sure that we're focusing on the right things. So if you are interested potentially down the line or in general in learning a little bit more about patient and public involvement in research and how you could be involved, not as a participant only, not just answering a questionnaire or not just, you know, kind of giving samples, but actually helping guide what happens and oversee that. And you can reach me at either michelleflood@rcsi.ie or ppi@rcsi.com. And Grainne and Deirdre will also, you know, get in touch when there's opportunities available. The other thing that we do at an institutional level is make sure that our students learn from people who are living with particular diseases or health conditions, and we are increasing our focus on that. So having patients come in and educate our students and say, look, you know, this is really important. And as Grainne and Deirdre will talk about, we know that education of healthcare professionals has not been sufficient to date around Sjögrens, and that's led to people, you know, taking a long time to get diagnosis, and, you know, their healthcare professionals not necessarily knowing as much as they should about a condition that's actually quite common. So, you know, that kind of myth that it's rare, we need to kind of you know, debunk that and make it clear that, you know, it is something that every healthcare professional needs to know about, and how to support patients who are living with Sjögrens. And then finally, RCSI is very much committed to community engagement at local and national levels, and particularly focusing around Sustainable Goal 3 for the UN SDGs. And we have lots of programs where patients and the public can get involved in various events. You know, maybe you might not like to kind of, you know, be that person giving the information, but maybe you might like to come to some of our events. So do keep an eye on the RCSI website for them. But I won't, I suppose, say too much more of those things. I want to focus back in on patient and public involvement and the other opportunities to get involved, because the work that we've done with Grainne, Deirdre, Eileen and Monica through Sjögrens Ireland has really made a huge difference to the research we do. So involving patients and the public in research means that it's better. So it improves the quality and relevance of what we do. We do better things because we understand, you know, not to design something that's impossible for people to achieve. And also it improves research outcomes. And we've worked very closely with the Sjögrens community on a couple of projects that have given us the information we need to try and advocate or leverage some change, both in education and also in research. So you'll hear a little bit more about that, but I would just encourage you, if the Sjögrens team do reach out to you and ask you to give some information, there might be a survey or an interview, whatever it is, please do, if you feel up to it, participate, because that information allows us to try and change things, or it gives us a bit of a evidence base to say, no, this is a problem and this is something we need to look at. So please do understand the impact that your inclusion has. I work as part of a big network, so there's 7 universities working together to try to improve the way research to include patients in the public at all stages. And I'd encourage you to take a look, if you are interested in research, even tangentially, take a look at their website and sign up to their newsletter, because it's absolutely great to see everything that's happening around the country. And they've just launched a new notice called the PPI Opportunities Notice Board that'll give you an opportunity to see the types of things that you can help with. And you might find notices via this website. Also keep an eye out on social media. So the Sjögrens Ireland social media sites are brilliant. Some of you might be more formally involved, for example, like COSI and UPATI, or patient groups that work to try to make sure patients are represented fairly. And also, we do sometimes use traditional media, so radio and television, stuff like that. So that is what I wanted to say anyway, before I pass back to Joan. But thank you so much again for coming today. And please do, you know, if you see something coming relating to research, try and see if you're feeling well enough or you're feeling up to it, and whether you might like to be involved, because it makes a huge difference to what we do. And it really does help us spend our time better. So I will pass back to Joan. Thank you so much.
Thank you very much, Michelle. It does help explain what it's all about and how people can get involved. I'd just like to take this opportunity to introduce 2 amazing women that we've got to know recently over the last while. So I'm going to introduce you to Deirdre and Grainne Tynan, 2 of the co-founders of the Sjögrens Ireland Advocacy Group. Deirdre is a former archaeologist and currently an embroiderer. She lives at Sjögrens, and through her experiences, she's become a really passionate Sjögrens advocate. And she's one, as I mentioned, one of the co-founders of the advocacy group. To date, she has been integral in the design and analysis of a lot of the research that we've done. She's been involved in drafting and editing research articles that we put out, and basically some of the research is actually come from the surveys and studies that we've done together in partnership. Grainne Tynan is an occupational therapist, and again, someone who lives at Sjögrens. She again is another passionate Sjögrens patient advocate. And again, another one of the members of the co-founders of Sjögrens Ireland. Grainne has helped co-design the Sjögrens Research Ireland webpage. So for many of you who found the page, that's been a collaborative project between myself and the Sjögrens Ireland group. So a lot of the wonderful suggestions are coming from Grainne, not me. So you can thank Grainne for those. She's been involved again in analysing the results from a recent survey that we've done that's turned into a research manuscript. And I'm going to pass over to the guys. So they're going to give you some updates on what they've been doing recently.
Thanks a million, Joan. Hi, I'm Deirdre from Sjögrens Ireland. Welcome to our webinar. It's great to have so many of you here. Just going to check that I can, yeah, there we go. So today we're just going to run through who we are and what our aims are for Sjögrens Ireland. Feel free to use the chat box to make comments, etc. And do stick around for the community chat later, which I'm really looking forward to. So Sjögrens Ireland is a completely voluntary group. There are just 4 of us, myself, Grainne, Eileen and Monica. And the group came about because we all have Sjögrens and became really frustrated at the lack of understanding and advocacy for those of us living with the condition. So we decided to found Sjögrens Ireland to try and effect some positive change. We have been incredibly lucky to partner with some fantastic scientists and researchers in RCSI, notably Joan and Michelle, and the level of enthusiasm and commitment to improving things for those of us with Sjögrens is incredible. And we genuinely wouldn't be where we are today without them. So a huge thank you to them. So we have several aims. We want to provide support and educational resources for those of us with Sjögrens. We understand what it's like to finally get a diagnosis and not have resources in place to make sense of that diagnosis and help taking the next steps. We also want to promote awareness of Sjögrens among healthcare workers. We all know it's far more than just dry eye and mouth, and lack of the awareness of the systemic nature of Sjögrens is a stumbling block for many of us. Sorry, just dry mouth catching up with me. We aim to advocate for better services and care for those of us with Sjögrens and to focus on promoting research and forming strategic partnerships and to bring care in Ireland up to an international standard. Because we're all suffering with it ourselves and have jobs and kids, etc., we've had to really prioritise where we put our energy. And the feedback from previous surveys that you participated in clearly shows that a lack of understanding amongst medical professionals regarding the severity of Sjögrens and the wide range of symptoms associated with it are a major concern for most of us. So that's where we've been focusing. And on the screen now are the results of the post-webinar survey of 2021, and thanks to everyone for participating in that. It showed that over 50% of you saw physician education as an unmet need, and over 30% felt there was a need for better patient resources. So one of the things we've done about patient resources is on that website. I think the link has been shared in the chat box. Unfortunately, the survey also showed that for many of us, it takes over 10 years of symptoms to get a diagnosis. For me, it was 20 years. So we really understand those kind of frustrations. And we're trying to work at making things better. So to increase awareness among healthcare professionals and patients, we launched a poster campaign in April of this year in partner with RCSI and Pharmaceuticals. These posters are going to be sent to clinics and hospitals and primary care centres around the country in the coming weeks. So keep an eye out at your upcoming appointments and let us know if you spot them. A huge thank you to Joan and the graphic designer at RCSI for creating such beautiful posters. And thank you to all the departments and clinics for putting them up. The posters are available in digital format on our website. We put a lot of thought into the design. We wanted to move away from the image of just dry eye and mouth to a more systemic picture of Sjögrens. And I think they worked out really, really well. We also want to say a huge thank you to Professor Conor Murphy and Dr. Grainne in the Eye Hospital in Dublin, the Ocular Immunology Research Team in RCSI, Sabina Brennan and Pharmacists Ireland for supporting our activities. You might have seen we had some recent articles in newspapers. There we go. The Irish Independent and the Cork Echo. We feel it's really important to increase the visibility of those with Sjögrens. It can often feel like we're alone, but we're not. As you can see in the chat here as well, and it's likely that 1 in 200 people have Sjögrens, which is almost as common as rheumatoid arthritis and 3 times more common than lupus. So there's a lot of us out there. So by raising awareness through events like this webinar, we want to create a sense of community for those living with Sjögrens in Ireland. I am going to pass you over to Grainne now, who's going to talk about our advocacy and research projects.
Great, thanks very much, Deirdre. Sorry now. Yeah. So the RCSI researchers used the survey results that Deirdre was just speaking about from 2021 to write up a research paper and poster. We were invited to co-write the paper, so the patient voice would be incorporated into the project. For example, by removing the term syndrome and using a definition of Sjögren's that emphasizes the systemic features. This is in line with the patient movements internationally that are pushing for a change in the language we use to describe Sjögren's. You can see on the left there, Dr. Joan won an award for her poster at RCSI Research Day, and she also presented the poster at ARVO, which is a big eye conference in America. We're delighted to hear that the article will be published in the journal Health Expectations, which is due out later this year. And it will be open access. So we'll share the link on our social media when that comes out, and you can all read it for yourself. Thanks to everybody who took part in that survey. It's really been great. Another part of our mission is to help with education of both people living with Sjögren's and healthcare workers. So together with the team in RCSI, we have developed a website, and the link will be in the chat now. On the website, you can find webinars, podcasts, booklet, posters, research, and useful information both for people living with Sjögren's and health professionals. In the middle there, you can see Dr. Emily Grainne made an excellent video explaining her research with Dr. Joan in the Eye and Ear Hospital, looking at microRNA in the eye. And on the right there, you can see the current edition of our booklet, which is written by Sjögren's experts and is available to download for free from our website. And I'll just let you know, we have a second edition of that booklet coming soon. In terms of advocacy, we were invited by the Irish College of Ophthalmologists to present at their Listen and Learn event earlier this year. The event was for their board and members to hear patient groups' feedback. It was really great to be able to advocate for the needs of Sjögren's patients to this group. We presented, this was one of the slides we presented, and we talked through the following points. We made it clear that dry eye significantly affects quality of life for people with Sjögren's, that our experiences should be listened to, that we often have quite complex medical histories involving maybe multiple other autoimmune diseases. That compassion is so important. We're living with pain, brain fog, fatigue, like they might catch us at a bad moment, and that we ask for their understanding. Communication is really key. Like, we wish that doctors would CC us on letters and update our other doctors. Most of us are attending multiple consultants, and very often they're not talking to each other, which is just such a shame and a missed opportunity. That daily management is burdensome and sometimes quite painful. That wait times and appointments themselves can be stressful and emotionally draining. And that we ask them to understand that over-the-counter products like eye drops can actually be added to our prescriptions so that they could be covered by the drugs payment scheme, and that would be a financial help to us. In terms of other advocacy projects, we've been delighted to participate in several RCSI PPI program projects, and we hope to continue with this. And then our achievements since last year's webinar. So we were delighted to be awarded highly commended in the Patient Organisation Project of the Year at the Irish Healthcare Awards last year. We were granted membership of Sjögren's Europe, which is an umbrella organisation for 15 patient groups in Europe. We joined the International Sjögren's Network, which is a group of 28 countries around the world. We launched the first Irish website dedicated to Sjögren's, and we're bringing about new research in connecting scientists and patients. So now, in terms of future projects, we have been thinking about what changes we would love to see in an ideal world. And these are dreams, but realistically, we are 4 sick people with already very busy lives. So it's difficult to know how and when some of these might be accomplished. But I thought you might like to hear them anyway. We would hope in the future to apply for charity status, but this is a complicated and onerous undertaking. We would aim to reduce time to diagnosis, but how do you go about doing this? First of all, we would love to look at continuing professional development for healthcare workers.
Oh, 2 seconds.
sorry, if everyone can mute their microphone, that would be really helpful. We would love to work with medical schools to improve the education on Sjögrens. We would hope to also include like trainee doctor, dentists, opticians, nurses, OTs, physios, so that every trainee healthcare worker leaving medical school had a good understanding that Sjögrens is common, serious, and systemic. We would love to improve the access to diagnostic tests, both for Sjögrens itself and its complications. For example, things like salivary gland biopsies and ultrasounds, pot screenings, autonomic dysfunction testing. We'd also love to access to a wider range of treatments in Ireland. And I would draw your attention to the Sjögrens Expertise Centre in the Netherlands. Hopefully the link will be in the chat. And they are beginning trials at the moment of stem cell therapy for Sjögrens dry mouth, which is a very exciting new treatment. So we would love to see, treatments like that being available to Irish patients as well. However, if you look at a group like Endometriosis Ireland, they have had to campaign tirelessly at a political level for years to achieve change. But hopefully change is coming to them, and hopefully it will come to us in the future too. We would love to see specialist Sjögrens clinics, similar to what's already available for lupus patients in Ireland, for example. We would hope that it would be staffed with specialist rheumatologists and have an integrated MDT who all have expertise in Sjögrens. Again, we would love to look at the Dutch model in the Sjögrens Expertise Centre in the Netherlands. Their model of a one-stop shop it just sounds fantastic. So on one day, a patient can go and get tested by, dentists, doctors, ophthalmologists, rheumatologists, and, look at a full picture by an MDT over the course of one day. And they offer follow-up support from advanced nurse practitioners, which I think is something that's really lacking in Ireland. We would hope for additional financial support for dental treatments and over-the-counter products, which could be done by increasing, for example, the drug payment scheme coverage for extra products. In future surveys, we might ask patients questions about their Sjögrens expenses, and these facts and figures would really add strength to our case, our advocacy projects in the future. So we'd encourage you to take part in our surveys if you can. We would love to see access to international drug trials in Ireland. For example, the Necessity trial is a large €15 million drug trial taking place right across Europe at the moment. But because there's no Irish centre, we don't have the opportunity to take part. There are a few new drugs for Sjögrens that are showing promise in the early stage trials at the moment. But as things stand, we in Ireland won't get access to them for many years until they're launched. We would also hope to work with bodies that support patient groups in Ireland, like the Irish Platform for Patient Organisations, Science and Industry. Okay. Now, while there are few services, as I just listed, specifically for Sjögrens patients in Ireland, we want to show that there is still a lot of resources Sjögrens patients can access. And these are all listed on our website, and the link will be in the chat. It's listed under the useful information section on our website. So eye tests are free for medical card holders and PRSI workers and their families in Ireland. In addition to this, OCT scans of the back of the retina can pick up early signs of eye damage. So patients on the drug Plaquenil or hydroxychloroquine, which many of us are on, are advised to get these regularly. Many opticians now offer OCT scans at a small cost. For example, Specsavers and Vision Express, it's just 10 or 15 euros. So you may wish to get this done annually. Due to the rollout of Sláinte Care, primary care teams should be in every area around Ireland now. This means you can discuss a referral with your GP for physio, OT, social work, etc. For example, you might be having difficulty cooking due to joint pain and fatigue. Perhaps an occupational therapist could look at strategies and equipment with you to make it easier. It's a free service, but just be aware that unfortunately there will probably be waiting lists. The Dental Treatment Services Scheme is for medical card holders to access free dental care in Ireland, but this is within limitations. However, there are some conditions listed that allow for extra treatments, and Sjögrens is actually on that list. The drug payment scheme, Niamh will be talking more about that later. And the National Maternity Hospital has a rheumatology care clinic for women with arthritis before, during, and after pregnancy. I've listed a number of health lines there that are really useful and are often manned by qualified people such as nurses. Under accessibility, having a hidden disability can make things like standing on a bus very difficult. So Transport for Ireland have introduced a badge and card called Please Offer Me a Seat. You can find information on their website about that. There's also an international scheme called the Sunflower Lanyard that discreetly indicates to people around you that you may require additional help, support, or even a little bit more time. These are now becoming popular for use in shopping centres, airports, hospitals, libraries, and so on. Just this week, Wicklow County Council have announced that they're going to have special parking spots reserved for Sunflower Lanyard users, which I could imagine would be very helpful for some people. There are lots of great websites now with really great information about Sjögrens Foundation that you can access around the world. I'll particularly draw your attention to the American Sjögrens Foundation website, which is just an amazing resource for us all. I'll also draw your attention to the Lupus Encyclopedia. Their section about Plaquenil is a must read for anybody who's on the drug. The Sjögrens Advocates page is an amazing resource by Dr. Sarah Schaefer in America. She has Sjögrens herself, and her sections on how to advocate to your doctors for yourself are really excellent. Endometriosis Ireland, their section on employment law is just new out this year, and it really is a fantastic guide for anyone with a chronic illness on what your rights are as a worker in Ireland. And there's a new website down the bottom there, #BeyondDryness, that's very good. It's written by a rheumatologist in Boston who trained in Harvard. On the right there, we've got several courses for people with arthritis or chronic illnesses run by Arthritis Ireland, HSE, Chronic Pain Ireland. These can be excellent in terms of learning about how to self-manage a chronic illness, but also a great way to connect with people in your locality who might be going through a similar situation to yourself. I'm just going to hand back to Deirdre for our last slide. Thanks very much.
Thanks, Grainne. So just wanted to say, please follow us on social media at Sjögrens Ireland. We're on Facebook, Twitter, and Instagram. And you can contact us at sjögrensireland@gmail.com. Please do share your ideas with us. It's all about you. And also, it's really important to take part in the post-event survey that will be sent out in the coming weeks, because it really helps us to direct future research and to understand Sjögrens better. And I suppose one of the things to do is that we can often end up dealing with Sjögrens privately, because it can take us so long to find out why we're feeling sick. And we end up not talking to people about it. And then there's not much, it's not very well understood. And so it can be quite tempting to kind of keep it private, and which is understandable. But I think it's really important that we all start talking to people about Sjögrens, our friends, our family, so that the word Sjögrens becomes a little bit more familiar to people. In the same way that we have the posters around, that people will see the word Sjögrens, and it won't be so mysterious. So do share your ideas with us. We'd love to hear what you think we should be doing. And also, if you've any expertise in like charity sector, medical fields, marketing, etc. There's only 4 of us. The more people we have on board, the better. But because we're small, we're trying to stay very focused. So hopefully at some point in the future, we'll have the means to have general volunteers. But at the moment, we're looking for people specifically with expertise in medical and charity sectors. Overall, our perception of the future for Sjögrens in Ireland is actually really positive now. There are new drugs and treatments in the pipeline. The patient groups are getting more organised and connected online. And PPI, as Michelle was talking about, is putting patients at the centre of our healthcare. So the future is bright, and thank you for taking part in that. You've really, really helped, and your support has been incredible. As we said before, please do hang around for the chat at the end, because I think that could be really interesting to meet people with Sjögrens and have a bit of a chat. So I'm going to hand you back over to Joe now to introduce the next speaker. So thanks, everyone.
Thank you, guys. That's such an incredible list of things that you've done, and also the and as you can see, the amount of resources and time and effort the guys have put on the website. If you haven't yet bookmarked that, make sure you bookmark the Sjögrens Ireland webpage. It is continually updated with new information that the guys find. And as they said, we're going to have an opportunity at the end to come back in and have chats with the guys. If you have thought of any questions, do put them in the chat box and we can bring them to the group chat at the end. Next, I would just like to take this opportunity to introduce you to our next panelist. We have Niamh Dillon. So Niamh is a pharmacist and she currently works in research in RCSI. And she graduated from the University of Brighton in 2010, and she worked in the NHS in Portsmouth and London until 2016. She moved to Dublin to take up a post in the Royal Victoria Eye and Ear Hospital, where she worked as a clinical pharmacist for 5 years. She has a postgraduate qualification in general pharmacy practice and applied statistics, and has experience in community pharmacy. She's also had experience working in a COVID vaccination centre, and she's been involved in pharmacy education. She now works on the HSE funded programme MEC Digital. That's a project in RCSI, and it stands for Make Every Connection Count, and it's a really fantastic project. So it explores ways to facilitate health conversations between professionals and patients in the community to improve outcomes.
Yeah, thanks very much, Joan, and thanks to everyone, in particular Sjögrens Ireland, for organising today. I'm delighted to be involved, and I did attend as an attendee for the last 2 years as well, and I found it really informative for my practice as a pharmacist in terms of the small gains or the things that I might be able to help with. So yeah, it's brilliant to be involved. So I'm going to fly through some of the information on these slides. I will share them afterwards, so if anyone has any questions, just let me know. Can you see that there, or is it cut off for you?
You can see it down as far as communication. Is there something else underneath it?
No, that's fine. It's just looking a little cut off on my side, but that's fine. Hang on if I minimize. Okay, perfect. Yes, so the plan for today is just initially to talk about over-the-counter therapies that might help with your symptoms. And this really is just an update of information from last year's webinar and from the year before as well. I'll talk a little about access to medicines, so the community drug schemes and dealing with drug shortages, which I'm sure a lot of you have heard about in the media or have been directly impacted by. Then I'll move on to managing your medicines. So as Grainne mentioned, you know, a lot of people are on multiple medications for different conditions. So just things to bear in mind when you are on many different medications, monitoring and side effects, and then communication. So communication at transitions of healthcare. Okay. So firstly, if I just start with the topical eye drops, I guess they're the most plentiful on the market. Obviously, when we think of dry eye for Sjögren's, it's not just the dryness, but it's the active inflammation on the eye surface. So you have all 3 layers of the tears affected, the mucus, aqueous and lipid layers. It's really important to use your eye drops, your lubricating eye drops regular. And I know a lot of this information is going to be, you will already know some of this information, but it's hopefully there's going to be a little bit extra in there that can be of use. So the benefit of using it regularly and not just when required is that you are optimizing that surface of your eye. With the eye drops and eye ointments, obviously things that are slightly thicker, that have a higher viscosity, they're going to stay in contact with the surface of your eye for longer, which is why ointments are best for nighttime in terms of staying in contact for longer. They can be used as well during the day, but some of them, particularly ones that have paraffin in them, can blur the vision. And in Sjögren's, it's more common that you're going to be using eye drops frequently, so 6 or more times a day. Therefore, it's really important to use preservative-free preparations. This wouldn't be as critical if someone was just on eye drops once or twice a day, but when you are on them that regularly and there is already inflammation there, you want to minimize anything that could lead to toxicity on the surface of the eye. If I just move on here. So this table just shows some of the products that are available on the market in Ireland that can be covered by the medical card or by drug payment scheme. So as already was mentioned at the Listen and Learn event, it is important for ophthalmologists or for prescribers to know that they can put these things on a prescription to make it easier for people to access. There are different ingredients. A lot of it is trial and error, finding the one that works for you. Just some images there on the right show the difference between the single dose units or the multi-dose bottles. In the past, it used to be that just the single dose units were the ones that had no preservative in them. But in recent years, we do have more multi-dose bottles that are preservative free. And this is down to an advance in technology in terms of the patented device that they're used or that they are supplied in. So if I just move on. Oh yeah. Okay, so these two images on the left here, they might be a little bit blurry, but it's just to show you when I mentioned about the patented mechanism that drops can be distilled in. So they might look a bit familiar to you, but it means that you can, have assurances that the drops that you are using don't have preservatives in them. So they have like special membranes in them, a pump technology that really help. If the product that you're using, if the shape of the bottle doesn't suit, and some of you might have dexterity issues, particularly people that have arthritis as well, or just joint pain, you might find that some of these aids can help. So there's plenty on the market. You might have a look online. Your community pharmacy is likely to keep one or a few of these, and they can fit many different products. Some other just general tips in terms of eye care. Obviously, it's important to be mindful of environmental factors. So, during the season of where hay fever can affect people, try and minimize your contact with pollen if this is a trigger for you. And this might be things like when you come home in the evening, washing your face, your hair, changing your clothes, maybe even putting Vaseline at your nostrils or even on your eyebrows to try and prevent pollen from just staying in contact. Because if you have pollen and you have an increased histamine release, it's more likely that it might affect your eyes and it might lead to having to rub or scratch them. So you want to try and avoid this. Then, of course, air conditioning. So if you're working in an office or even in your car, if it's possible, try and avoid it as much as you can. But if you can't, then just try and take regular breaks. And the regular breaks apply for screen time as well. If you're using a computer a lot, and think of the 20-20-20 rule. So every 20 minutes, see if you can take a break for 20 seconds just to focus on something 20 feet away, just to help with the eye strain. For anyone that has to use eye drops frequently, it's really important to be mindful of infection control. So hand hygiene, where possible, wash and dry your hands before you put in your eye drops. If you can't do this, if you're out and about and it's not really practical, just have an alcohol hand sanitizer with you. Always use your eye drops within their expiry date, never share them with other people, and avoid the nozzle tip touching the eye as well, just to prevent introduction of infection. Another slide on eye care is just to be mindful of sunglasses. So just make sure that the sunglasses that you're using, they do block UVA and B rays and they carry a CE mark. So don't just base it on the darkness of the lens. Close fitting wraparound sunglasses will also help with pollen exposure as well, so they can help to minimize it. Ideally, especially this time of year, wear sunglasses even when it's cloudy. Just in terms of UV protection, wear a wide brim hat if you can, and try and minimize your exposure to direct sun for long periods of time. Contact lenses. So I know these aren't always possible or they're not always comfortable with dry eyes, but even if you are wearing them just for a few hours, be mindful that they often do have an element of UV protection, but it's not going to cover the full surface of your eye. So still take the other precautions. The warm eye compress. So this is really good for stimulating meibomian gland secretion. And this helps with the lipid layer in your tears. So if you can, try and get into a routine of using a warm eye compress, and this might be a microwavable one. There's plenty that are available. If you can, try and use it for 5 to 10 minutes. Twice a day would be optimal, but whatever works for you. Okay, mouth care now. So I've just separated the mouth there into sprays, rinses and gels. If anyone hasn't watched the webinar from last year, Dr. Eleanor O'Sullivan gave a really comprehensive talk on mouth care. So I won't go into all of it here. There is an excellent resource if you want to go back and listen to that webinar she gave. But there were some really useful tips that she gave in terms of trying to keep a moist mouth environment. I guess the main thing is just to know that the role of saliva, you know, in terms of rinsing away food particles and bacteria and neutralizing acid, without adequate supplies of saliva or good quality saliva, you are more at risk of dental caries and gum problems as well. So it's really important to try and mind your dental health. Use these saliva substitutes as much as you need to, so whichever one works for you. If community pharmacies will usually have a range of these available. Some other things just to be mindful of is the class of drugs called bisphosphonates. So you might have heard of alendronic acid, ibandronic acid. These are used for prevention and for treatment of osteoporosis. They have some other indications as well. Now, there is a rare side effect with these where they can cause osteonecrosis of the jaw. It is a rare side effect, but for people that have Sjögren's, they are twice as likely as a member of the regular public to have this side effect. Now, with this, it's more the risk is higher if there's been any type of trauma to the jaw, and this might even be like a tooth extraction or an abscess or an infection. So just another word of caution that if you are on these medication and you have Sjögren's, make sure that you link in regularly with your dentist and take care of your mouth environment. For oral thrush, there are products over the counter. So there's Dactarin oral gel. If you think that you have thrush, speak to your pharmacist. They will just check the medication you're on, make sure there are no interactions with anything that you're taking. And it's important as well, if you have dentures, to make sure that you're rinsing and scrubbing them daily. If you do have thrush, to make sure that you're not going to reintroduce the infection. Pilocarpine, I've just mentioned it there briefly. It is a prescription-only medication. It can help with saliva because it stimulates secretions. There are a lot of side effects that come with it because it increases other secretions too, like sweating and urine production. And so if it is being started by your prescriber, the main tip is to start low and go slow and titrate and see how you tolerate it. I couldn't speak about mouth care without mentioning smoking. So the HSE has a huge amount of support out there for people that want to give up smoking. And in terms of benefits to your mouth environment and your mouth health, stopping smoking is brilliant and really advised. And in terms of your general health, you might have heard this before, but stopping smoking is the single best thing really that you can do for your health. So in every county in Ireland, there are stop smoking clinics and there are stop smoking advisors. They can provide personalised support, so one-to-one support, group support. They can also provide 12 weeks of free nicotine replacement therapy. And so this is really cost saving. And it's for anyone, not just medical card holders, but for people that pay privately for their prescriptions as well. So this is a cost saving of over €400. And it means that you have that support. So you have the psychological support and the pharmacological support to help you quit and stay off cigarettes. So when you're taking nicotine replacement therapy, usually you'd have a combination of long acting. So this would be a patch, and also fast acting nicotine, which would help with the cravings. So there are different types out there. There are sprays, lozenges, you have the inhalator, whichever works for you. Just also another note, and I'll put this in the chat when we go to the break, but there is a really interesting RCSI My Health lecture series video on vaping, and it goes into the evidence and the current science behind it. In general, and Dr. Eleanor O'Sullivan mentioned this last year as well, vaping, it's not recommended for people with Sjögren's either, because you're introducing warm vapor into the mouth, which can exacerbate the dryness. Just quickly on nasal products. So there's less out there, but there is still, this isn't comprehensive in any way. There might be own brand products out there. Neilmed nasal gel is relatively new, but really good in terms of moisturizing your nasal cavity. And also just one example here of a sesame oil nasal spray. So sesame oil has traditionally been used for in nasal preparations. So it could be nasal drops or sprays, but just be careful if anyone has food allergies to sesame. So this wouldn't be appropriate. So just check the ingredients if you're buying any of these products. Okay, move on. Likewise with vaginal dryness, so there are many different moisturizers and lubricants on the market, and some of them have changed name recently, so people might be familiar with KY Jelly, that's now KY Connect. I just have an underline here for Silk, it's a lubricant. I've just noted that because there was a recall. Now it was back in March, but just in case anyone uses that lubricant, there are a couple of batches that were affected, and it is best to return it to your pharmacy or to dispose of it. So again, I'll put that link in the chat when we get to the break, just in case anyone needs to check the batch that they have at home. And these moisturizers and lubricants that I've listed here, they are non-hormonal, so they are safe for anyone to use. And I would say, you know, find what works for you. With the moisturizers, they could be used every second, every third day, and don't be afraid to use them regularly. Kind of like the eye drops, you know, if you want the optimal environment really just to prevent symptoms, using regularly is recommended. There are prescription therapies as well. I won't go into them now, but there are local estrogens and different formulations that can be used that you can speak to your doctor about. In terms of the menopause, so obviously one of the symptoms that comes with menopause is vaginal dryness. So the lack of or the reduced estrogen causes less collagen production, and in turn this causes less elasticity and lubrication. And it's not just, you know, it's not just right when you're in the thick of the menopause, it could be in the perimenopausal period as well. So people from their mid-30s or even much younger might start to get this symptom of vaginal dryness. So just keep it in mind, and, you know, don't hesitate to try some of the moisturizers and see how you find them. Vaginal thrush as well. So if there are if you think that you're symptoms of this, you can speak to someone in your pharmacy about it. There are pessaries and there are creams over the counter that can be bought, and they also can be accessed on prescription. If you try one of these therapies and it doesn't clear up the thrush, or you're getting recurrent thrush, then speak to your prescriber. They might want to take a swab and just make sure that they can get the right antifungal to treat your infection. Okay, access to medicines. So I'm just going to touch on two common schemes, but there are others out there. The drug payment scheme and the general medical scheme. So the drug payment scheme, this caps the price of prescription drugs to €80 per calendar month. It's not means tested. Anyone that lives in Ireland for over a year can apply for this. A whole family can qualify for it. So it can be a single person, it can be someone and their partner. Children and dependents are also included. You can start the process by registering online. They just need a few details of you initially, including proof of address, but it is really useful. Even if you get regular prescription medication that doesn't come up to €80, there might be the odd month where someone else in your family needs to get something, you know, of course, steroids or an antibiotic, and that might push it over 80. So I would say it's really recommended to sign up for that. The general medical scheme, so that is the medical card, that is means tested, and this means that you pay a much lower amount for each individual product. So it just depends on whether or not you are below a threshold whereby you qualify for it. So if for anyone under the age of 70 who qualifies for the medical card, this means that they pay €150 per item on their prescription, up to a maximum of €15 per month. And if you're over 70, it's up to a maximum of €10 per month. And that cost per month, that again, it applies to the whole family. So if you have different people in your family or different dependents, then they can avail of this as well, and it'll be capped at the €15 per month. Now, most medications are covered by both of these schemes, but there are occasionally treatments that aren't. So it might be an unlicensed medication or an off-label one. And there are situations where people on medical cards can apply to have their medication covered if it's not already covered by their medical card. And you can speak to your pharmacist about something called the hardship scheme. So this is where an individual application is made on your behalf. Usually it requires that a prescription is started by a consultant in a hospital. And they need to justify that there is nothing else on the market that is suitable. But speak to your pharmacist if you think this is an option. Okay, sorry, I'm racing through these, but I'll have plenty of time to talk to you afterwards about them, and I can share this screen as well, or share my slides. Just a note for where you get your medication. So obviously I know I'm talking about over-the-counter medicines. You can also buy over-the-counter preparations or general sale pharmacy items online. But if you are buying them online, just make sure you see this logo on the screen where you're buying them. So this is a regulation that came out of the False Medicines Directive in the EU. So across the EU, every website that sells over-the-counter medication should have this logo on them. In Ireland, it's not legal to obtain prescription medication without a prescription online. So I really would discourage that if anyone has done that. But for over-the-counter ones, it's completely fine as long as you make sure that you are going to a reputable website. Okay, so shortages. Now, just even this week, there was more information on RTE about shortages in Ireland, and unfortunately, they're not going anywhere. It's probably something that we have to manage for a long time. The aim with any type of supply is to make sure of continuity for a patient. So in some cases, we might have to change a strength, a form, change from tablet to capsule, or a brand or a different supplier. But where possible, your pharmacist will communicate this to you in advance. There are many different reasons why shortages can apply. And the HPRA, so the Health Products Regulatory Authority, they publish a list and they keep it up to date on their website. So anyone can go on to this website. Patients, doctors, pharmacists, anyone can look and see for the most up-to-date information on when that shortage can be resolved. Okay. Interchangeable medicines. So kind of based on that with the drug shortages as well, pharmacists in Ireland, due to the Health Act from 2013, we are able to make generic substitutions. So this means that the active ingredients are exactly the same, the strength's the same, and it is administered in the same way. But it might have different excipients, so colours, flavours, non-active substances. Obviously, this isn't ideal for a lot of people, especially if someone relies on identifying their medicine by what it looks like. It's not great to have to change them month on or month in, month out. And where possible, pharmacies will try and avoid this. It's not always avoidable. Sometimes it depends on what the wholesaler can get in. The main thing, I guess, that we need to prioritise is making sure that the active ingredient is continued, especially for critical medication, immunosuppressants, epileptic drugs, cardiac, diabetes medication. It's really important that we can make sure that you are getting your active strength. But where possible, we should always be communicating if we are making a change, because some people can be quite sensitive to changes. And I'll speak about that in my next slide, actually. So again, just talking about multiple medications, a lot of you might be on immunosuppressants. So you might be on things like biologics or biosimilars. It is important to stay up to date with your vaccine schedule. So before you started on an immunosuppressant, your prescriber might have checked that you had all your routine vaccines. I would encourage you to get the annual flu vaccine and also to consider the pneumococcal vaccine, especially for those of you that are over the age of 65. So these in Ireland are free to anyone over the age of 65 or anyone under the age of 65 who has a condition that weakens their immune system, or if they are on any medication that weakens their immune system. When you're on multiple medications as well, obviously this goes without saying, but it is important to stay up to date with your routine blood tests and checkup appointments. Because for a lot of them, we do need to keep an eye on kidney function, liver function, things like ECGs, you might have to get these monitored as well. And this is important as well for any over-the-counter or topical preparations that you might be starting on. Just highlight to your pharmacist when you go into them that you are on immunosuppressant therapy already. Okay, move on to the next. A little bit of a lag here. Oh yeah, okay. Just one slide on hydroxychloroquine. I know a lot of you might be already on this. So we class this as a disease-modifying anti-rheumatic drug. The best thing is to be on the minimum effective dose. So your rheumatologist will try and tailor this for you. There is monitoring that comes with it for long-term treatment. And Grainne mentioned the eye examinations as well and the OCTs being available. Toxicity, so there is a risk of retinal toxicity with hydroxychloroquine, so it can damage the layer at the back of the eye. This is largely dose related, so the risk increases the longer that you're on it. So it's just important to stay up to date with those eye examinations, particularly if you're on it for more than 5 years. The most common side effects with hydroxychloroquine are gastrointestinal, nausea, vomiting, diarrhea. These can settle when you are established on treatment, but there are some side effects to keep an eye out for the whole time that you're on it. So any eye changes, if you were to get any dizziness, lightheadedness, a racing heartbeat, anything like that, make sure that you speak to your prescriber about it. I know some of you were interested in talking about side effects and being sensitive to side effects. So just here, this table just shows there are many different types of reactions from medication. Some of them can occur really quickly within an hour, and this would be like anaphylactic reactions. Some of them might take much longer, so they could take up to days or weeks to show. So it is important, if you think that you have a reaction to a medication, even if it's weeks after starting something, it could possibly be related to it. So you should speak to your prescriber about it. There is evidence out there to suggest that people with Sjögren's are more sensitive to drug-related side effects. And this is across the board with different things like antibiotics, the bisphosphonates that I mentioned previously, and even drug anaphylaxis. So while these might be still rare occurrences, there is a slightly increased risk compared to the regular public that don't have Sjögren's. So with this in mind, obviously, you should have a certain element of caution with starting any new medication. Obviously, you don't want to avoid treatment if it's needed, but it does mean just having that discussion with your doctor, with your pharmacist, let them know of any concerns that you have, and then where possible, they will titrate slowly and with monitoring. Just go back one. There are lots of medication that can cause or worsen dryness. Oh God, I flew on there saying thanks a bit too early. Sorry now. Just this is my last. Oh, sorry, I think it's just. Let me see if I can go back again. Yeah. Jumping around a little, sorry about that. Okay, there's a lot of text on this slide, so I apologize for that, and I won't go into it all in detail. But I guess just to highlight that there are many medications out there that are known to make dryness worse. It's not that they, so say for mouth dryness, it's not that they damage the salivary glands, it's just that they decrease the salivation rates. And one group of drugs is anticholinergics, which cause this quite commonly. Their effects can be additive. So if you're on multiple medications that have this effect, it can get worse the more that you're on. This is also of particular concern for anyone over the age of 65 or people that are on multiple medications. And it's not just dryness. These medications also cause other side effects like confusion or a higher risk of falls in the elderly. So there is a bit of a trend towards trying to deprescribe where possible. Now, obviously, we don't want to stop anything abruptly, but it is important to speak to your doctor and have a medication use review. So go through the medication that you're on, see if all of them are still required, or if there's any doses that can be tapered down. Okay, so I think I'm there now. Communication at transitions of care. So if you ever need to go into hospital, if it's for an outpatient appointment or you have to go in for an elective surgery, it's really important to bring an up-to-date list of your medication with you. You might want to keep it on your phone. And this picture here is one that you can print off from the HSE website, which is quite useful because you can put all the medications, what they're for. You can include over-the-counter or complementary medication as well. Raise awareness early. So if you do happen to go into hospital for an admission, it's important when they are asking for your list of medication that you highlight any medication that you take on an ad hoc basis. So if you do need to rely on lubricating eye drops or on a saliva substitute, highlight that to them. They mightn't be able to get it immediately. So the earlier that you can flag that up, the better chance you have of not being left in discomfort while you're in the hospital. And this applies across the board. If you need to go into a dentist or to a GP or even to a pharmacy, it's always useful to have that list of medication. Okay, so if there is any take-home points, I guess the main thing is just to open that channel of conversation with your pharmacist. There is a wealth of information on the Sjögrens Ireland website, and I find that I personally am always recommending pharmacists to go and look at it for their own education, but also to be able to help their people that come in to see them. Highlight when you are starting any new medication or having a change in dose. Just chat to your doctor, chat to your pharmacist if you have any concerns about this. Keep an up-to-date list if you can and include topical products. And also, just if there's any pharmacists or healthcare providers on this call, just bear in mind that, you know, for a lot of people, they have years before they get the official diagnosis. So if you have someone that comes in and they're complaining of dry mouth or dry eye or aches and pains, you know, just think of the small gains, think of the things that you can do to help them. And it is more common, I guess, than some people might think. So, you know, it's very likely that if you work in a community pharmacy, you're going to come across people that have it. Okay, that's it. Thank you so much. Thanks to Deirdre, Grainne, Eileen and Monica from Sjögrens Ireland, to Joan and Michelle as well. And I'm sorry, I think I went way over there. I should have been keeping a timer. So I'm going to...
We won't say anything. It was fantastic information. You have a couple of people emigrating now to Ireland based on the information you gave there. Fantastic. I actually hadn't even, that's something I wasn't even aware of around the interchangeable medications. We have a couple of just comments around the eyedroppers. Again, somebody else wasn't aware of them with the AIDS. Even I find it difficult, so that's phenomenal to have that there as well. I'm just going to ask you some of the questions that appeared in the chat box. I'm probably going to pronounce it wrong. Xylene, or apparently it's out of stock in the UK as well. And you had mentioned around the shortages. Is there any idea when that's coming back, do you think?
No, I don't know, but I can actually check the HPRA website. I'll just see now if they have said anything on it. Let me see.
Oh yeah, there's a resort you mentioned. So basically we can just go check.
Yeah.
That's fantastic, because a lot of things do go off license or do are often become unavailable, and it's actually great to be able to check.
Yeah, now the ones that they include on it are ones where they've deemed them to have an immediate or a high impact on people. So if it's a particular brand, they mightn't necessarily put that on there unless it's the only brand available. But I'll check the Xylene. If I see any information, I'll put it into the chat. So
for everybody in our audience there, if anybody would like to raise their hand and shout out a question, which if you're happy to turn on your microphone and camera, do so. Otherwise, I'm just going to go through the questions that appeared in the chat box, but we do encourage you to join us here. So if anybody has a burning question there for Niamh, they'd like to speak with her, do turn on your camera or at least your microphone so we can hear you. While you're doing that, I'll get you to multitask. We had a question around vaccines, but that's gone in, and there's a response gone in there on the COVID vaccines. We did have a question around, do you have any tips for meibomian gland dysfunction?
Joan, I'm happy to take that if Niamh wants while she's looking up.
Yeah. No, poor Niamh, I have her multitasking.
Yeah, I have her multitasking. Sorry, I'll put my camera back on. I'll try to. So yeah, so it's a great question, and there's another question I saw below, which is really interesting about. I think it's both are from Dee. So, you know, if you have a lot of mast cell activation, how do you manage that with one worsening the other? And I think that's what makes Sjögren's quite challenging to treat, because often, you know, one intervention can worsen something else. And, you know, that's kind of why, you know, the research into the new types of medicines are really important, because we're using medicines in most cases that aren't really designed for Sjögren's. They're treating a symptom that, you know, arises, you know, as a result of the disease, but you know, it's often around symptom management rather than, you know, kind of getting really into managing the condition. So at the moment, it tends to be a balancing act, and it's a little bit of trial and error, which isn't great. It's about finding the balance between, you know, what's most comfortable, and that's really done at an individual patient level, with, you know, your kind of team. So it tends to be just sort of that balancing. And then with meibomian gland dysfunction, it's something that definitely is worth checking in with an ophthalmologist or an optician about it. We would normally recommend warm compresses, so just using, you know, kind of a compress with warm water. Sometimes artificial tears can help some people, and some people will need prescribed antibiotics or steroid drops depending on how bad it gets. So the kind of first place to start would be around the warm compresses. Is probably a good place to start. And thanks to Therese for her question as well about the COVID vaccine. So absolutely, COVID vaccination definitely important. I know there's lots of people here from all around the world. So depending on your national policy, and also, you know, in most cases, there's an inclusive approach to vaccination. So, you know, if you don't fall into the age category where it's recommended, you can still have a conversation with your healthcare professional team and see if they feel it's suitable for you. You will normally have access in most countries at the moment. And then while I have it, James will probably talk about omega-3s later. So I'll say we might hang on to those
Vicky
for a
Fox
little
has
bit
her
of
hand raised
context.
there. Do we want to let Vicky come on, and do you want to unmute yourself, Vicky?
Yeah, hi. Well, first of all, thank you very much for the great presentations and for the work you do. So I've got all the symptoms of Sjögren's syndrome. However, I've been diagnosed with a Zika syndrome due to a negative biopsy. And so I find it very difficult to get any support because you get a bit dismissed despite having all the symptoms, but it says Zika syndrome in the records. So is that something you also raise awareness or keep an eye on or work on in that area?
The short answer is yes, we are aware of it, and it is something we're working on actually. There's a lot of stuff in the research community around that as well, that the current diagnostic criteria were established to help uniform people who are going into clinical trials. So they're not really fit for purpose. So they're not really identifying patients who actually have Sjögren's disease. So there is a general trend in the research world to stop relying so heavily on those and to start to look more holistically at patients who are presenting. So that is ongoing, and with the work with the advocacy group, we are aware that you might not actually be antibody positive. There's a whole seronegative, there's a whole like a different sort of presentations of disease symptoms. And we're trying to raise awareness around those too, because obviously the quicker or the earlier you are diagnosed, you can get better referral. And that's what I'm aware of from, let's say, from my world in science. And what about Michelle? Have you come across anything there?
Yeah, and it's a really great question. And there's one thing I'd say, like a lot of these conditions and a lot of diagnoses, you know, not every test is perfect as well. So I suppose, you know, particularly with a biopsy, you know, you need to sample, you know, an affected area. So, and again, I suppose from learning from all of the friends in the Sjögren's community, it's very tiring to keep kind of having the symptoms and keep raising it, and people saying, oh, well, you have a diagnosis, and kind of challenging that can be, you know, kind of can feel very, very difficult. But as Joan said, hopefully some research that's ongoing is looking at the diagnostic criteria, because they have traditionally just been, I suppose, more research tools rather than, I suppose, tests. So what I would say is maybe don't give up on that if that's possible, you know, because definitely the treatments of the symptoms are going to remain the same, but it will be worth maybe seeking at some stage, you know, a review of that diagnosis, and, you know, maybe is there something available now that might, you know, look at it slightly differently. Because
thank you. It's just that I've seen a top rheumatologist and the biopsy was negative, so you just now basically a closed case, and they just say, well, it's just Zika syndrome, and but I have all the other symptoms, you know, the whole lot. So yeah, it's a bit frustrating, but anyway, thank you very much.
Yeah, and we have had, you know, conversations with people who have said actually they did get, you know, a negative biopsy, but it did transpire down the line, you know, that they did then have, you know, kind of did get a diagnosis. So that was shared at previous webinars, people had that experience. So I'm afraid we don't have any alternative test options, which is a problem yet, but hopefully in the next few years some of the research might translate into clinical stuff.
Yeah, well, thank you. It's just good to hear that you do keep an eye on the Zika syndrome.
Yeah,
exactly. As well. Yeah, thank you.
Just mention up for that saline ointment. Unfortunately, no, I don't see any data return, and I'm not sure if it's actually impacted the Irish market the same as the UK. There is high-low night still seems to be available, so that's another option. But yeah, I hope it's not affecting you too much. Sorry about that, Niamh.
Thank you for the check for us, Niamh. So to Niamh and Michelle, I have a question in around an alternative to local steroids if somebody had an allergy to them.
Is that for the eye or for the skin?
Yeah.
For lichen sclerosis.
I probably just recommend speaking to your prescriber to go back to them, because if it's for that condition, you know, I'm wondering, is it a particular type of product, because it's likely that you might need topical steroids.
Yeah, and also just the to remember that a lot of people are actually allergic to not necessarily the medicine part, but the what we call excipients. So things like preservatives or you know, other ingredients in the medication that aren't necessarily what the drug or the active part. So I would always kind of suggest looking at the list of the full list of ingredients, and there's going to be lots of them, but some people have allergies to preservatives rather than the medicine, and then it gets recorded as an allergy to the medicine, but actually it was the, you know, the kind of bulking agent, or, you know, some of the other bits and pieces that are needed in that product. You know, oftentimes preservatives is a culprit. So, you know, if you do have an allergy, you know, to the product, think of it as the whole thing and try and figure out, because an allergy to a steroid-based product, it wouldn't be terribly common, like possible, but, you know, it would be more common to be allergic to maybe a preservative or some other factor in that product, if that makes sense.
Perfect. And we have Nicola Davis has your hand up. Do you want to turn on your microphone there and have a chat with us?
Yeah, thank you. And thank you for all giving your time for this seminar. Really appreciate it. I'm sure we all do. I've recently had my tear ducts blocked at the bottom of my eyes, and it's temporary, but I could have it done permanently. Do you know how successful it is? But I do still need to use my eye drops and the Nytol gel at night.
No, maybe Niamh might know more about the success rates. I know for punctal occlusion, the little plugs that go in, they can be quite good. And for the cauterization, the permanent closing of them, you sort of run the risk of, so you go from very dry eyes to having excess fluid. It's sort of counterintuitively having more kind of weepy, drippy eyes. We can have a look at that, because we do work with the ophthalmologists in the eye and ear, and I can get back to you on definite numbers. And they are fantastic. Emily Grainne and Conor Murphy, like they would have definitely know the numbers off the top of their head around the success rates. I know the punctal occlusion works really well. And I know that kind of one of the caveats to the cauterization is you can end up with sort of more secretion, more because you're retaining stuff now. It's got nowhere to go. But I don't know I don't know the exact figures.
Okay, thank you.
I'll put that on the list, and we'll get back to you about that.
Yeah, lovely, thanks.
So we have been having quite a few questions around omega-3, but we're going to have that covered in the next session. Is there anybody else who wants to come on and ask a question? Or we can just, well, we're going to continue to look through the chat boxes. Is there anybody else who wants to join in the conversation? You can raise your hand so we can find you in the little raise hand icon. Otherwise, I'll have a look here through the questions. Somebody else, another question.
A question. Hi, Niamh. Thanks so much for that presentation. It was fantastic. A question we have had by email on several occasions was that their pharmacist told the patient that pilocarpine wasn't covered by the drugs payment scheme, but we've been assured that it actually is. Can you speak to that, Niamh?
Yeah, I think it's probably a misconception there, because it's not readily available. So it's one that I think, Michelle, correct me if I'm wrong, but there's not a licensed manufacturer of it available in Ireland. So it needs a particular code. So then there needs to be an application sent in for it. It can get reimbursed. It does need to be started by a hospital consultant for the first prescription anyway. So they might just need to show evidence of that or communication. I guess one of the good things that happened in recent years is that Health Mail has really improved these types of things. So if there was a particular doctor that was interested in starting it for that patient, often they can communicate directly with the pharmacy, or the pharmacist, should be able to communicate directly with the prescriber to get that. So there are means around it. Yeah.
That's great, because it's actually extremely expensive.
I hope everyone's back. I know it was a short break, but we're trying to stay on time. So we're going to invite our next speaker, James Barlow, on, and I'll just give you a little bit of background around James. He is a pharmacist with a PhD in medicinal chemistry, and he has a particular interest in natural products and chemistry. He's worked in community pharmacy prior to accepting an academic position in RCSI, where he teaches pharmacognosy and evidence-based complementary and alternative medicine. His primary research is based on the organic synthesis of novel molecules based on natural product scaffolds, while also being involved in diverse educational and practice projects.
Okay, thank you, Michelle. Thank you, Joan. Thank you to everybody for listening to me this morning to talk to you about complementary and alternative medicine, often shortened as CAM in the literature. So I'll use that acronym. So in my talk today, I want to give an introduction as to what is CAM on a very simple level, to describe really that it is a diverse range of practices, and then take it from there and talk a little bit more particularly about its potential use in Sjögren's syndrome. So I'd be very interested to hear your comments as we go along. So I'll start off with a definition because I think that might be helpful. A lot of different definitions exist out there. I'm not claiming that this is the most perfect definition, but it is certainly a definition. And if we start off with saying what we think CAM is and also what it isn't, I think we'll all be on the same page. So as you can see there, it's listed as the diagnosis, treatment, and/or prevention, which complements mainstream medicine by contributing to a common whole, by satisfying a demand not met by orthodoxy, i.e. conventional medicine, or by diversifying the conceptual frameworks of medicine. So this is quite a broad definition and it incorporates various different aspects, and I'll discuss what these mean in a little bit more depth as I go along. But that's a start-off definition. Because of the fact that it isn't by definition mainstream, it's typically not taught to any great extent in conventional healthcare programs. Now, this varies significantly across jurisdictions and across the world. And certainly I teach evidence-based CAM within the pharmacy program in RCSI. However, other pharmacy programs and many other healthcare programs get very varying amounts of exposure to CAM and various different attitudes towards CAM. You'll also see the same thing when, as a patient, you decide to investigate the world of CAM or decide to discuss it with any of your healthcare team, be that a doctor, GP, rheumatologist, be it a pharmacist, physiotherapist, any other person you may be engaging with at all. They will have very different opinions and very different attitudes towards CAM use. But I would straight off say that it's certainly something that needs to be talked about. You can't form a really clear opinion about something if you don't know what it is. And I think by discussing it, defining it, and making clear patients' attitudes towards it and taking it into the mainstream is a way of ensuring its potential positive use, but also for highlighting issues of concern, and also for ensuring that a person's entire holistic care is taken care of. And Niamh did highlight a moment ago in transitions of care that it is really important to say to any given healthcare professional that you're engaging with exactly all of what you're taking. And that really much includes CAM and CAM practices. So I'd urge that point. You do see another term in the literature, which is something called integrative medicine. So what does this mean? Obviously, this is a very general term as well. It could mean anything if you just read it and didn't realize what it was seeking to mean. But as you can see, here's a definition again: healing-oriented medicine that takes account of the whole person. So this holistic approach to every aspect of you as a person. So clearly when people approach a healthcare professional, they often approach with a particular question in mind, with a particular, for example, issue in mind. And for example, obviously in the context of the audience today, you might be specifically discussing Sjögren's, but you might be discussing it along with having other concomitant conditions or other questions. And it may not be the direct symptoms of the condition you might actually be wanting to discuss at a given moment. It could be something that is perhaps ancillary or secondary to that. So certainly taking into account the whole person, their body obviously, but also their mind and indeed their spirit, is what integrative medicine seeks to do. And this includes all aspects of lifestyle. So it's really considering your entire everyday life. It's not just focusing on one aspect of you, it's looking at all of you. It emphasizes the therapeutic relationship, i.e. the relationship you have with the person engaging with you in the delivery of whatever treatment is being talked about, and makes use of all appropriate therapies. both conventional and alternative. So you can possibly see the distinction between these two definitions in that the word both is highlighted here, and it's seeking to say, let's make the best of both worlds if possible. Let's not see these as opposing things. Let's see them as things that could possibly work together. So with that in mind, and we have a definition, let's turn our attention to who uses CAM. So obviously this again is quite a general point, but nonetheless studies both nationally in Ireland and certainly in worldwide, they actually have quite a commonalities in terms of generalizations as to who uses CAM. So this is CAM for any condition, by the way, not in my first few slides, not really specifically Sjögren's. But in general, the users of CAM tend to be female. So there tends to be a predominance in that regard. Also tend to be in middle age, tend to have actually more education, often to university level, but certainly more education than none. Tend to have more than one medical condition, and in some cases may not have specific conditions, or maybe they do, but they haven't been diagnosed as having said condition. And I was interested to listen to some of the patients' comments there in the last conversation, or rate their own general health as poor. So their own perceptions of how they feel themselves may lead them to turn towards CAM, and you can possibly see easily why this might be. So certainly the demographic characteristics and the health characteristics independently are predictors of CAM use. And this is as well established, as I say, in many international studies. So in the context of Ireland, and bearing in mind, I appreciate there's an international audience, but I do wish to talk about the Irish context. In terms of CAM prevalence or use in Ireland, again, broadly for any use, this hasn't been as widely surveyed as you might think. And in fact, we have to go back to 2002, which, as you can see on the slide, some points here referring to a survey called SLAN. So this was the National Survey of Lifestyles, Attitudes and Nutrition. It's quite a broad survey, and it wasn't specifically looking at CAM. That was only one small aspect of it. But nonetheless, you can see that it showed, it repeated the survey. Sorry, just a little feedback there. Hopefully that's gone. It showed that by period, that the prevalence rate for visits to CAM practitioners went up by 7% in that period of time. So this also mirrors other countries, whereby it certainly seems to show that people in general are visiting and therefore using complementary and alternative medicine practices more. That's interesting. Most of the information found in this Irish study did mirror the studies in other countries, but typical Irish CAM user was again highlighted as more well-educated, affluent, middle-aged, employed. Interestingly, self-employed people were more likely to visit CAM practitioners. That was something that seemed to be a bit more Ireland specific. And also specific users of CAM tended to be people that suffered from pain, anxiety, and depression. So you'll appreciate from this list that we're really talking about patients with chronic conditions as the more typical users of CAM. So perhaps you'll see that many of the, I suppose, generalizations that are being talked about here might well apply to patients with Sjögren's syndrome. One important point, of course, is cost and access to indeed any form of healthcare, but in the context of complementary medicines, the costs of these can be really, really significant. And there is a strong variance in cover amongst the three main healthcare insurers in Ireland as to what they will cover. And of course, it also specifically depends on the individual plan that you might have. So you may not actually be aware, should you be interested in using a form of CAM, that it may well be covered, at least partially, by your healthcare insurer. So it's certainly worth checking that, but it isn't a broad absolutism across the board. And this is also true in other jurisdictions. I would say that in different countries, you actually get different or differential usages of CAM. And what I mean by that is that in some countries, there might be in another. So it varies from country to country. Okay, so I suppose an obvious question following up on that is, well, why? alternative medicines. And there are many reasons, of course, and some of these might resonate with you as to why you might use CAM. We can broadly divide them into two subtypes, one being so-called positive motivations and the other therefore naturally being negative. So if you looked at positive motivations, or what could be seen as positive motivations, they might include the following. So there might be a perception that the CAM that might be turned to is effective, that it works, and certainly that it's safe. You often see this in conversations about natural products or what's perceived to be natural. It's natural, ergo it is safe. I, of course, would challenge that significantly, and it's not a generalism that can be considered true, but it is something that you see, and it is something that is bandied about on the internet a lot. And it also brings up the point about information sourcing and where you get authentic, believable information from. And unfortunately, we're bombarded with a lot of information, many of which simply isn't true. So we have to rely on evidence-based sources of information when we're trying to get information about health, and indeed anything else, of course. So that would be one positive motivation. Another would be what's called philosophical congruence. So this simply means that, for example, if you start reading or finding out about one particular form of what's considered complementary medicine, it's often found that patients find an identity with that. They're happy with the description of where this is coming from. It sits easy with them, and the philosophy and underlying thinking behind it allies or agrees with how they view life. So some of the beliefs in some forms of CAM might be attractive to certain people. Control over treatment. Often there's a significant involvement from the patient in, for example, the selection of individual remedies or so-called remedies that might be used. And we all like choice. So the inclusion of you as a patient in obtaining choice over your treatment is something that we would all like. But I would argue that, participatory decision-making is something that we're seeing, thankfully, more and more of in conventional medicine. So hopefully you might see some of these points also arguably very true for conventional medicine as well. They're not solely associated with CAM. Another one would be good patient-therapist relationship. So often in a CAM intervention, you require many visits to a practitioner. It's a one-to-one often scenario, and typically you build up a positive relationship with that practitioner. And a lot of the evidence perhaps behind some of these may be down to this interaction that is developed positively with the practitioner, that's a strong aspect of the actual care itself. The non-invasive nature would naturally be appealing to people. So, for example, in comparison to certain conventional medicines that might be given by injections or might be given in other ways that could be perceived as, for example, painful, most complementary treatments are not. And certainly that would appeal to people. People don't like invasive treatments, so that's understandable. Also accessibility, maybe you can go in and get it yourself on the high street, or maybe, you don't have to wait for many, many weeks or months for an appointment, but that may or may not be the case. In some cases, it could be considered also a pleasant therapeutic experience. For example, you might have a massage therapy, an aromatherapy, and you might find that pleasant, as opposed to, for example, again, going back to the example of an injectable therapy being given, wouldn't necessarily be a pleasant experience. So these are some of the reasons why people might turn towards CAM. I already mentioned, interestingly, patients that use CAM often tend to be more affluent than those who don't, but that's a generalism. On the other hand, negative motivations would be the opposite of this. So motivations that would be based on, for example, dissatisfaction. So being unhappy with conventional healthcare for the particular condition, perhaps, that's being dealt with, or, for example, the care pathways. You might feel that the given treatment that you're getting isn't really working for you. It's not really effective. And we talk about, the lack of medications that are really first line available for many conditions. And therefore you can understand what people would feel dissatisfied. Maybe adverse effects might be well known and documented for several prescription medications, and people would believe or feel that, herbal therapy or some other form of CAM therapy wouldn't have adverse effects. Now, that isn't necessarily true, but that may be what people believe. So the perception about adverse effects is something that I would again challenge. poor doctor-patient relationship or poor pharmacist-patient relationship or poor physio-patient relationship might be cited. But again, you could challenge this. Moving towards more participatory decision-making and building holistic relationships with your healthcare providers is certainly something that is far more aware to us as educators, and we teach, Michelle, for example, is an expert in teaching communication skills. We're constantly, I suppose, developing and leading on with regard to those aspects of care in educational models today, perhaps more so than would have been seen in more patriarchal models of the past. But certainly building up relationships with patients is not something that is solely to do with any one individual therapist. It should be something we promote for all. Again, points about waiting times and the like have already been made. Other aspects that perhaps could be considered as negative would be rejecting science and technology and of the establishment. You know, some patients may have beliefs for whatever reason that they don't believe in particular forms of pharmaceutical intervention. They don't trust big pharma. They don't trust vaccinations. They don't believe certain things about technology and science. And that might lead them towards feeling a bit more comfortable in using CAM. Again, we can discuss or challenge that point, but it is certainly one of the perceived negative motivations. And unfortunately, the last one would be desperation, whereby people just simply don't have any other, in their minds, choice. For example, it may be a scenario whereby there is no available other treatment for the reason that they're using it, or they feel that they've run out of every other option. So again, they turn towards what they see as a last chance saloon. So moving on from that then to more specific aspects of CAM, turning our attention to perhaps CAM use by Sjögren's patients. I have to say as a start-off point that this is not widely studied. In fact, it's hardly studied at all in the literature. So therefore, from the perspective of specific evidence-based interventions around Sjögren's and CAM, I don't have an awful lot to say, and that's the bottom line, to be quite honest. However, there are various reports, more anecdotal, some more individual reports, which give us information, but we can't really draw on for, giving information across the board, but interesting nonetheless. And reviews of the topics, there are plenty of those, suggest that Sjögren's patients use CAM for different purposes. So it might be for obvious, or perhaps what you might see as obvious symptomatic relief, for example, various Zika symptoms, that would be perfectly reasonable, but also perhaps to alleviate fatigue. And many CAM therapies are investigated specifically for fatigue, or more generally to improve quality of life indices, or perhaps maybe it's to aid relaxation, maybe it's for a mental aspect of their whole being. Maybe it's not necessarily for specific use directly to do with Sjögren's, maybe it's something more broad. And as you can see, that I have references on these slides which show cases in the literature and reviews in the literature. And this one, the most general reference, goes back to 1998. So certainly there is a need for more up-to-date research in this specific patient population. Where do you go, or what for information about CAM therapies, and where do you publish if you're interested in researching it? Well, it's certainly broadly a developing field. It doesn't have a strong research tradition as, for example, many conventional medicines, and there's various reasons for this. Lack of infrastructure, perhaps lack of interest in practitioners that are educated, for example, in statistics, in trial design, in various aspects of, evidence-based care that need to be built into research. But that doesn't excuse the fact that it still needs to be done to the very same level that is necessary for publications and research into conventional medicine. It's just simply not acceptable from a scientific perspective to ask for anything less. So all forms of intervention should be assessed in exactly the same manner from the perspective of research design. But I've highlighted some useful publications in the scientific literature, but these are more for academics or professionals who want to look at information on CAM, but some of them are also a little bit more accessible to patients. But bottom line, I would say that more research in the use of CAM, the reasons, the motivations why, the types of CAM they're using, the outcomes that are being obtained in patients with Sjögren's is certainly needed. So let's turn our attention then, as you'll perhaps have noted, the original slide introducing what I was going to talk about was talking about quality, safety, and efficacy. That are three words that pharmacists often talk about. And we need to consider them when talking about CAM practices and products. So it could be talking about the actual intervention, or it could be talking about something somebody is taking that we consider a CAM product. So there are specific aspects that I'd like to address. And firstly, patient factors. So we mentioned earlier that patients with chronic disease often typically tend to be users of CAM. So you can see that this could obviously include Sjögren's patients. And the thing is that these patients are typically often taking other medications. Maybe in the case of Sjögren's, it's medications for Sjögren's, but maybe it's for other things as well. Maybe secondary Sjögren's, maybe it's a patient with concomitant other conditions. So perhaps more likely to be using other medications, and therefore the big issue is that there is the potential for drug interactions. So drug interactions can occur between two conventional drugs that the doctor prescribes for you or that you buy at the pharmacy, but they can also occur between those medicines and complementary practices and products. Some patients have different ways in which they handle drugs in their body. We're all different. We all handle drugs slightly differently. Maybe we have different organ functions. This is also true naturally as we age. And as we age, other aspects of the way our bodies work change perfectly naturally. And then indeed also the stage of your life. And in women, of course, pregnancy and menopause are important aspects that need to be considered. And very importantly, the disclosure of use. If I told you that most patients do not disclose specifically that they're using CAM practices and products that might include supplements, nutritional products, herbal medicines, lots of things, to their rheumatologists, to their doctors, even to their pharmacists, unless specifically asked, I wonder, would you be surprised? So, you know, that is certainly the case. And we find that, and this is what we train our learners, our students, that they need to specifically ask this question in an open, non-judgmental way. So certainly disclosure of use is hugely important in the world of CAM. So there would be some patient factors. What about product factors? So this is where we really zoom in on quality, safety, and efficacy. So again, it depends where you are in the world, how your medicines are controlled in terms of law. But in Ireland, there's obviously European and Irish legislation that ensures that the medicines that are prescribed and sold in pharmacies are appropriate quality, safety, and efficacy. So for prescribed and authorized medicines, they need to demonstrate these three to a high degree. This is not necessarily the case with CAM practices and products, and therefore you just simply can't stand over them to the same degree. Now, there have been drives, particularly coming from Europe, with regard to specifically products purchased in pharmacies that include, for example, herbal products, to at least try and improve quality and safety aspects, because that's fundamental. Efficacy is more difficult to actually demonstrate, and there are some ways around allowing companies to bring products on the market because of demand and because of free choice, that they don't have to demonstrate the entire exact same efficacy, but I'll get to this in a moment. But certainly quality and safety are hugely important. I have a reference there that, for example, shows a particular case. It's an anecdotal report about exacerbation of Sjögren's syndrome following ingestion of a herbal supplement. So that you do see papers like that in the journals, which highlight issues whereby people consume or do particular things that can actually make the reason, in this case, Sjögren's syndrome, worse rather than better. So they're useful for our perspective for highlighting toxicity and quality concerns. The other point that it needs to be thought about, of course, is the practitioners. So I'm talking to you as a pharmacist, and so are my colleagues, and you've also, of course, you're under the care of various other qualified, regulated healthcare practitioners. We've all undergone a particular length of study, and same in other countries, to then allow us to enter a register, a professional register that is regulated. And even the use of terminology like pharmacist, etc., is regulated. However, this is not the case in the complementary and alternative medicine world. Now, again, it does vary depending on what country you're in the world, but in Ireland, traditionally, because of our law and our legal setup, complementary medicine practitioners are free to practice. They have been, and they still are. Now, I have to say that a lot of positive thinking CAM practitioners want to be regulated. I'm not saying they don't. They certainly, many of them do. Many of them have undergone long periods of training, perhaps degree programs. For example, in some countries, you can do degree programs in things like herbal medicine, but you don't have to. That's the point, to be one. You can set yourself up as one of these with very minimal qualification. The government in 2001 signalled an intent to regulate and did set up a working group specifically recommending regulation on certain types of CAM practitioners and said, well, there should certainly be self-regulation. But as of today, that still hasn't happened. There is no statutory regulation. There are some professional associations, but they're not legally binding. Now, this isn't true in other countries. For example, in the UK, there is regulation of chiropractic and osteopathy, but that's all. In other countries, there may be some further, depending on, as I've said, the pattern of CAM that tends to be used in those countries and the history and traditions, but it varies hugely. So you need to bear that in mind depending on where you are in the world. But certainly in Ireland, this is the situation. So that basically means, in essence, anybody that wants to can call themselves a CAM professional. So then if you wanted to turn your attention to the kind of CAM, because it is, or the kinds of CAM, it is a broad church, what type of classifications can we put in it to understand the diversity of what's actually out there? And in fact, there's over 100 types of CAM been described. So it's really a maze. It's really difficult for patients. It's also difficult for healthcare professionals trying to get their head around the diversity that's out there and trying to wade through which of these, if any, can actually be useful and which of them could potentially be harmful and which of them just don't do anything. So we can divide CAM practices and products into, as you can see on the slide here, 5 different categories. What I've called natural product-based therapies. And these, as to me, are particularly interesting because I'm a pharmacist and people go to their pharmacy to buy herbal supplements. They go to buy other forms of food supplements, and they also buy these in, for example, health food stores and in other places. They also buy them online. So natural product-based therapies are of my particular interest, but you also have other kinds. For example, manipulative and body-based therapies. So this is typically some sort of movement-based therapy, and it might include something like osteopathy or chiropractic. We've got alternative medical systems that would include things like acupuncture, reflexology, that would believe in completely different systems of belief, ultimately. Then you've got psychological approaches, which are really interesting, actually. And these include, obviously, therapies that are mind-based, and they're quite diverse in their use. And then finally, very much out there in the fringes would be things calling themselves energy therapies that usually don't involve even touching the person at all. These, from the scientific perspective, are very hard to really give a lot of understanding and, frankly, credibility to, purely from a scientific perspective anyway. So let's turn our attention to a few of these. I'm obviously not going to go through every form of the over 100 plus forms of CAM and put you all to sleep, but hopefully I'll highlight a few of those that maybe perhaps might be a bit more relevant to you. So let's start with the discussion of natural products. So this, again, is a broad term. It could mean lots of things. So it could include, for example, things like vitamin supplements, minerals, and indeed, of course, we get vitamins and minerals in our food. So where does something stop becoming a food and start becoming a medicine is a big question. Then there's food supplements, things like probiotic supplements, which you can get in foodstuffs as well, and you can get as capsules or other forms of what looks more like a medicine. Then you can get things like herbal medicines as well. Now, these natural products can be purchased sometimes by an individual at a retail site of some sort and taken, or they could be given to you by a practitioner, for example, a naturopath, by a herbal medicine practitioner, by some other form of CAM practitioner, or they could be as part of what we call a complex system of healing. So that would be the traditional medicine systems of various countries, and they're more developed in some countries and more ancient than in others. I'll mention a couple for completeness. So let's start off with talking about nutritional supplementation. So certainly in the context of various aspects of Sjögren's that would be relevant, there is relevance here. There certainly is an established relationship between what you eat and drink, your nutrition, and the ocular surface health. And certainly then when you start to delve into that and start looking at, is there any sort of link between what we're putting into our bodies and then, for example, the occurrence of conditions like Sjögren's, it has been shown that certain both minerals and vitamins have been shown to be deficient in some patients who have Sjögren's. But that doesn't necessarily mean that immediately you should go out and buy these and supplement them, because it isn't absolute proof by any means, but certainly it's an association. So things like iron, selenium, and vitamins, particularly B12 and B6, have been shown to be deficient in some studies. Also, Interestingly, changes in intake of certain nutrients have also been demonstrated, and this includes things like vitamin E, vitamin C, and the balance of omega-3 to 6 fats. I saw there were some questions coming in about omega-3. It's one of the hottest topics in healthcare, and I'll talk about it in a little bit more depth in a moment. But then you have to ask yourselves, are these causative or are they a consequence? For example, as you'll all be well aware, and far more than I am, what you actually eat can actually, for example, in some cases trigger symptoms. So therefore, people might tend to avoid certain foods, and they might unfortunately then be avoiding certain vitamins if they were avoiding those foods. So depending on your diet, you can actually be manipulating your intake of nutrients. There have been mixed results, unfortunately, with dietary supplement studies. So there's no absolute proof that if you take any of these vitamins and minerals, that they will actually help the symptomatology of your condition. There is in fact an argument that you should optimize your diet and get a more holistic, using that word, approach. And that's very true in the context of oil supplements. And we can take it broader beyond Sjögren's into other aspects as well. For example, cardiovascular health and other aspects of healthcare that we need to consider, particularly as we age. Another point, and it's allied to something that was talked about earlier, which is smoking. Something that perhaps patients and people don't know is that smoking reduces the levels of vitamins, various vitamins, particularly vitamin C. So that's important. If you are a smoker, you need to perhaps think, I might need supplementation more than if I'm not. So that's something to bear in mind. What about supplementation then more depth? Well, vitamins A, C, and D are present in the eyes, thinking about the eye, they're needed. D and B help your immune and your nervous systems, and patients with dry eye conditions can have deficiencies. So if you've been documented as being truly deficient through a blood test, then you do need supplementation. That's absolute. Nobody would argue with that. But if you're not deficient, it's not as clear that you're going to get much of a benefit if you proactively decide to use vitamins as a preventive strategy, if you don't have a deficiency, but you want to try and be proactive. So that's interesting. But these, it's an evolving topic, and for general health, you see releases from the RCSI and other authorities advising us around this. And for example, this year, vitamin D intake was recommended across the board. So, and that's a very recent thing. So certainly, it's an evolving topic. I would say, though, for those of you who choose to take vitamin supplementation, if you're taking vitamin supplementation within recommended doses, within the recommended reference nutrient intake, it is a relatively safe thing to do. Okay, the concern might be that people might be taking multiple vitamins or things that they don't realize also have vitamins in them, so multi-ingredient preparations, and therefore they're taking additive doses, and they might not really be aware of that. So it's good, for example, to bring in all of your supplements to a pharmacist and say, look, well, this is what I'm taking, go through them and see what you think, just in case you're actually multiply taking too much vitamin A, as an example, because you can take too much of various vitamins, particularly A and D. I would say particularly caution should be taken if a patient is pregnant, or as well if they're taking multiple products, as mentioned. So what about plant-based products then? Moving on from what you might see as more nutrient-related things. So plant-based products could again include foodstuffs, but it could also include medicines. So in Ireland and in other countries, the way in which you as a patient might get a medicine that happens to be from a plant could be in different ways. And this is where people, I think, get confused. So I'm hopefully going to demystify it a little bit for you. One way is that you could get what we call a herbal medicinal product. Now that could be on prescription, or it could be something you buy over the counter. And there's a picture of Senecot tablets, which is a herbal medicinal product that you can get over the counter. So these types of products legally have the exact same status in terms of quality, safety, and efficacy as do synthetic medicinal products, okay? They just happen to be from plant sources, okay? So we can certainly say that they've gone through the same rigor in terms of quality, safety, and efficacy. However, then we turn our attention to those that do not fall under those categories, which is a huge amount. So I mentioned earlier that in Europe, there was an attempt to try and rein in the diversity of often herbal products that were available out there, very little information, no quality control really, and no information for patients. So under a directive published some years ago by the EU, they identified a group of products that they called THMPs, which stands for traditional herbal medicinal products. So these types of products must meet specific requirements. So companies that had products in the market were allowed to say, were allowed to apply for the product to be allowed to be marketed as a THMP, but it could only do that if it met certain criteria. So basically, these have to have the exact same quality and the exact same safety as do the herbal medicinal products, which was a fantastic advance. But instead of having to demonstrate the same efficacy levels that conventional medicines go through, i.e. clinical trials and the like, they were allowed to demonstrate that they had traditional use, and hence the name traditional herbal medicinal products. There's a range of these in the Irish market for various things, and they're for specific things. So I wanted to show you an example, and I'm not endorsing any product I show, I'm showing you products as examples. So this is an example of an Irish product called Peace and Calm. I draw your attention to the red box, and literally it says a traditional herbal medicinal product used in adults for the relief of symptoms of mild mental stress and to aid sleep, exclusively based on long-standing use. So you see, it's defining it as a particular type of product for a particular thing and relying on this traditional use. It can't be used for other things. That specifically is what it's used for. But this was a great advance in terms of trying to get products out there of good quality and of good safety. But a lot of companies didn't go down this route because it was very expensive. And that left a huge range of products on the market still as food supplements. These, by definition, are foods. They're not medicines. So these are regulated by food law. They're very variable in quality. We, for example, have done studies on various brands of products marketed as food supplements, found that some certainly, fair enough, did contain what they said they did, but a lot of others contain nothing or very little. And you can see, again, there's an example here, and you'll notice it says food supplement. So yes, you can see here that we can get access to plant-based products in many different legal and in many different quality-based ways. The same is true in other countries, but that's, in terms of the way that they're broken down or laid out may be different. In terms of herbal medicines, I want to turn my attention to these for a minute. So certain herbal medicines you saw could be available as THMPs, but many of them are not. In essence, what is a herbal medicine? So herbal medicine is actually a mixture. Okay, so if you were to take 2 paracetamol tablets to compare this with a conventional medicine from your cabinet right now, and you took them, you would be taking 2 tablets containing a defined quantity of paracetamol. There wouldn't be anything else in it, just one substance, paracetamol. But herbal medicines are mixtures of up to thousands of substances, and only some of these substances might actually be active. Now, a lot of the others may do nothing, but we don't know. So simply, they're very, very variable. A root of a plant might be different to a flower. If it's picked in March, might be different to September. The way in which extracted, it may differ from solvent to solvent, liquid to liquid. So there's lots of different things. Now, some people, herbalists, will say that these mixtures are actually important and that they work together to improve the effect. But certainly you'll see that they aren't by definition, therefore, really, really complex. And some of these might actually oppose each other. I wanted to draw your attention to another distinction that's worth bearing in mind if you have an interest in herbal products, and that's herbalism versus going into a pharmacy or health food store and purchasing a herbal product yourself. If you go to somebody who is calling themselves a herbalist or practicing as a herbalist, they will typically give you herbs themselves. They will design a herbal prescription just for you based on your entirety, holistically, all aspects of you, and they'll often emphasize detox or cleansing aspects of herbs, which is the belief of herbalism in its original sense. They'll believe that these mixtures work together, and they won't necessarily rely on rigorous scientific studies. They'll rely on their traditional beliefs. On the other hand, if you go to a pharmacy and ask for a herbal product, or indeed into a health food store, now it depends on the product, some are available only in pharmacies, you'd hope, and I say you'd hope, that the supply of the product would be more evidence-based, it'd be more science-based, and that the person supplying it to you, in the case of a pharmacy specifically anyway, would have knowledge about A, the actual medicines they're selling, and that includes herbal medicines, and B, hopefully about the other medicines you're taking. And hopefully they'll apply a rational approach. So phytotherapy means simply plant therapy. And so hopefully they'll be applying, a scientific approach to their recommendations. So here's the distinction between those two. So you can see that there's lots of things to think about. So as patients with Sjögren's and their use of medicinal herbs. Well, actually, there's quite a lot of variability out there in terms of what's claimed to be used, what's claimed to be useful by patients with Sjögren's. And indeed, some dietary recommendations include the use of various spices within food that actually are known to be anti-inflammatory. And that includes two on this slide, which are ginger and turmeric. But again, here's a question. Can you use something as a foodstuff, and then when does it stop becoming a foodstuff and start becoming a medicine? So here's a list. I'm not, this is just an example of the products that you'll see out there. And in various traditional systems of medicine, they're used to various different degrees. So I thought it'd be useful to focus on one. I don't want to give you too many slides, so I thought I'd focus on turmeric, which is one herbal product that is often advocated for Sjögren's. So what is turmeric? Well, for those of you who like Indian food, you'll be well familiar with turmeric. It's a very bright yellow-orange rhizome, so it's the underground stem of a plant that is widely used in Indian food and allied recipes, and very, important for cultural reasons. But what about it as a medicine? So it certainly is used in the traditional medicine system of Ayurveda, which is in the Indian subcontinent. And does it have any active principles in it? Does it have any drug-like substances in it? Well, the fact is it certainly does. And we know, broadly speaking, or we think we do, what they actually are. So they're usually referred to as curcumin. So you often hear turmeric and curcumin in the same sentence, and that's why. However, although we know that these have activity, we know also they're not really well absorbed when you take them orally, and people take turmeric orally. So if they're not really absorbed very well and they're broken down very fast, how do we translate that into actually understanding if they have a beneficial effect or not? It's difficult. It's difficult to establish a meaningful dose. How much of these do you actually take before they start becoming pharmacological as opposed to being a foodstuff or a flavoring? Have they been studied? Is there any known benefit? Well, there are some studies, I have to say, that show some positive results with regard to extracts of turmeric, but they're mostly in animal models. They're not really in human studies. So you can't always, or you shouldn't ever really, translate directly from one model into another, from one species into another. It's, I think, fair to say that they show potential, but we don't know enough about them. The other question mark is, maybe there's a drug interaction potential with turmeric compounds, and that has been suggested because they might affect the way you metabolize or handle other drugs in your body. And there have been one or two reports, now rare I have to say, but one or two reports of toxicity, but that's usually in people taking very high doses. But it raises the point again of what is the important dose that is safe or the dose that is not safe. So that's turmeric as an example of something that you might be familiar with as a food, but also could arguably be used for medicinal purposes. Another foodstuff that I think is interesting to mention is grapefruit. Now, I'm not advocating grapefruit as a herbal product to treat Sjögren's. I'm highlighting grapefruit here because grapefruit is a good example of a foodstuff that can interfere with certain medications. So generally speaking, we think about grapefruit as something that we might consume as a juice or as fruit for breakfast. It may be beneficial if we just consume it alongside other fruits, that's fine. But what about consuming it with certain medicines? It's certainly known, and it is absolutely true, that grapefruit interacts with some medicines. In fact, even one glass of grapefruit juice can do this. And what does it do? Well, it typically causes the levels of various drugs in the body to increase. Now, it can reduce some, but it typically has the opposite effect, typically increases drug levels. And this could be problematic. You'd appreciate if you're on a drug that needs to be controlled carefully in your blood, and then you take something like this that could interact with it or interfere with it, it could potentially be a negative thing. And in the little red box there, I've taken an excerpt from the SPC, which is the information leaflet for professionals that we read about medications, and that for the drug hydroxychloroquine. And if you read through it, it says, caution is advised if consuming strong inhibitors, including grapefruit juice. So that's interesting and shows you that there is potentially a drug interaction here. But obviously it would also relate to the given drug in question. But I've highlighted grapefruit for you as a food constituent that we would generally think of as fairly innocuous, but can interact with certain medicines. So you should check with your pharmacist, is anything you're taking potentially going to interact with grapefruit? And it would only be really oral medicines that this would be an issue for, by the way. Things that you apply topically or on the eye would be irrelevant. In the context then of what's been talked about, what about other food constituents or natural products? What about fatty acids and oil supplements? So certainly there are many of these, and it's a bit mind-boggling to patients sometimes, but there, broadly speaking, are two fatty acids that we need. We absolutely need what's called alpha linoleic acid and linoleic acid. And we can convert these into other fats in our body, but the way and the degree in which we do this can vary from person to person. And the fatty acid metabolites produced from these in our body have various different roles, some positive and some out of balance can be considered negative. In the context of Sjögren's syndrome, it's been shown that intake of these is actually low. And that's interesting because then it raises the question, well, could you supplement with them? There was a review in 2002 of omega-3 specifically fatty acids, which is a subgroup of fatty acids, in the management of dry eye disease that said that it improved subjective symptoms. But then leading from that, a pilot study specifically in Sjögren's patients showed that it wasn't any better than wheat germ oil, which doesn't contain omega-3s. So the evidence is mixed with regard to fatty acid supplements of this type. But what about omega-6 fatty acid GLA, which is another one that you hear about? So this is found in evening primrose oil, and it's found in other oils too, things like borage, which is often called starflower oil, or blackcurrant seed oil. So this is a specific fatty acid. It is not one of the two essential ones. So it's called gamma linolenic acid, and it's not essential because we can actually make it in our own bodies. But in certain disease conditions, there is the belief that that those conditions don't handle it or don't make it as efficiently as they should. And therefore, there's an argument for its supplementation. And this is the evidence or the argument behind evening primrose oil in Sjögren's. It's been suggested by some small studies that ocular health has improved, or ocular symptoms has improved by patients taking GLA or evening primrose oil, not so much fatigue. However, these earlier studies were challenged in a recent review that said that wasn't the case. So there is counter arguments with regard to this point. The other point is that these supplements are very expensive. They're also not covered by medical cards, for example, and they can, in some patients, depending on other medications, have the potential for drug interactions. So you might think, well, this is just an oil supplement. It's from the seed of a plant. That's not going to be problematic. In general, that is true, but in a few cases, there are suggestions that we would need to take care. And that might include if a patient with epilepsy was on certain clotting medications or anti-clotting medications, or they were experiencing gastrointestinal side effects. So we would need to discuss this. Other aspects of herbals and natural products are those that are used within what I referred to earlier as so-called traditional medicine systems. So these include the traditional medicines of India and China. So TCM is traditional Chinese medicine. So often, for example, you have herbal medicines as a component, but it's not the be-all and end-all. There's other things too. They're, for example, included alongside things like massage, alongside acupuncture, alongside other aspects of the traditional medicine system. But specifically from the perspective of the plants that are used in these forms of traditional systems, from our perspective as Western scientists, although some of them may show interesting effects, there is also differences in beliefs. So they use what we would consider materials that might be toxic. Now, they may treat them in specific ways to try and detoxify them, but they do use materials we would consider toxic. They also use metals, and they also use certain materials of biological origin. So animal materials, there's lots of reasons why we wouldn't stand over the use of those. So traditional medicine systems outside of the European context are often different philosophically to the Western herbal medicine that we would understand it in Ireland and in Europe today. One aspect or one form of traditional medicine that I think deserves a little bit more discussion is traditional Chinese medicine, because actually it's been widely studied. Of all the forms of CAM, TCM has probably been studied more than any other in Sjögren's syndrome specifically. So therefore it deserves to be mentioned. So in the context of traditional Chinese medicine, if you're talking about the herbals that are used in them, they typically use mixtures of herbs. So that's straight away a complex cocktail. But certain herbals from the TCM belief system are used broadly in China. So white peony root's been on the market in China since 1998. It came from traditional Chinese medicine. It's been studied quite widely in primary Sjögrens, but there aren't products here that we would stand over in the context of quality, safety and efficacy of that material, or indeed any other TCMs in a European context. And actually a review showed that while certainly there's interesting data out there with regard to traditional Chinese medicines and particularly herbal products, we do not have enough information about exactly what's in them, about their control, how they're handled in the body, and their potential for toxicity. But certainly it's an area of interest. Another form or aspect of traditional Chinese medicine is acupuncture, but you can of course go to an acupuncturist. You don't have to go to a traditional Chinese practitioner solely to see acupuncture. And acupuncture is interesting because it is also incorporated into some conventional aspects of health systems in Europe. What is it? Well, acupuncture is sticking needles in particular places. And that's important, particular places in the body. So obviously that needs to be carefully done. It has been studied in Sjögren's syndrome actually, and some studies have suggested positive effects on flow rates of saliva or the feeling of a dry mouth or lack thereof. But overall they were inconclusive. So you can see a little bit, but not necessarily strong enough evidence to allow this to be incorporated in broad guidelines. A recent trial looked at it in terms of symptoms of dryness, but also pain and fatigue, and followed it up over 24 weeks. And in that particular study, it didn't perform any better than placebo, but they did see some changes in the immune parameters in the blood, and that was quite interesting. So it raised questions about, could there be a methodology behind how acupuncture might actually work? So that's interesting. Acupuncture, broadly speaking, if it's applied by somebody who's properly trained, is relatively safe, but there are concerns. You are sticking needles in a person. Clearly, they need to be appropriately placed, and there needs to be infection control in place. So there have been reports of problems in those regards in the literature, but if performed properly, it's relatively safe. In the context of other forms of therapy, I'm now getting to the end of my slides and to the more obscure forms. I'm including them because I believe you need to know what they are, but I'm not endorsing them. So certainly, for example, homeopathy is one of the more fringe forms of CAN. So homeopathy simply involves giving tiny doses of substances that are often immeasurable, and they're believed to be of substances that produce symptoms like the disease itself if they were given in big doses, which is a strange belief system. They're extremely, extremely diluted, so much so that there really isn't anything measurable in them at all. So it's very, very difficult from the conventional scientist perspective to understand how these could work at all. There's also the belief that shaking them is part of a crucial part of their preparation. What I think a lot of patients do is they confuse homeopathy and herbal medicine. So homeopathy can start off with a herbal origin in terms of the actual substance, but it's diluted down to an immeasurable quantity. So it is no longer considered, herbal. So be careful about that. Be careful if somebody is discussing herbal medicine with you versus homeopathy. They are quite different. Herbal medicines do contain active substances. Whether they work or not is another matter, but they do contain active substances. Homeopathy are very dilute substances, and therefore that's totally different. Homeopathy follows, again, an individualized approach. There's lots of different spin-offs of homeopathy, things like the batch flower remedies. You see these in Ireland. Again, they're diluted remedies. And overall, from a conventional perspective, I would have to say that I believe homeopathy is a placebo effect. Now, some other people would not agree with me, but that is my belief. It is a very, very dilute form of practice. It's difficult to understand how it could work. And from my perspective, looking at evidence-based, there is no trial in any condition in which homeopathy shows benefit. But I've included it here because I think it's important for you to know what it is. There's another form of therapy, and this is my, I think, second last slide, to consider, and this is called the MBMT. And MBMT is a group of therapies which stands for mind, body, movement therapies. So the older term was just mind-body therapy, but now we recognize that the actual movement is hugely critical. So I think it would be really helpful actually to have a discussion with a physiotherapist and discuss movement and the importance of exercise and the importance of movement. Perhaps you've already had this in another webinar, but certainly movement is beneficial for all, all conditions. And certainly the movement aspect of these therapies is probably a big part of them. But also the mental component is hugely important. So these therapies focus on the communication between body and mind, and they involve various different aspects such as emotional, psychosocial, behavioral, and biophysical factors. You can divide them into loads of different types. So for example, yoga. You might think of yoga as a hobby, but yoga has also been studied, for example, to alleviate chronic pain in various conditions, with some evidence base, I have to say, in certain conditions, not Sjögren's per se, but in other conditions. Qigong is another interesting one, which is similar to Tai Chi and is a series of gentle movements. When it's been studied, it's been shown that inflammatory markers in the blood reduce, similar to conventional exercise. But that's an important point. Conventional exercise has been shown to be anti-inflammatory. So if we all, whether we're well or whether we have a given condition, incorporated exercise into our everyday routine at the levels recommended, it would be beneficial for all of us. Now, it's easy to say that. It's another thing to regularly do it for me, for you, for anybody, but certainly there is evidence-based strongly that exercise improves inflammatory parameters in your body. But these types of therapies seek and might be more suitable for people who can't do certain forms of exercise. So for example, Tai Chi is very gentle. You can do Qigong sitting down. You can adapt what might be suitable for you. So you've got to kind of interrogate them and see, well, maybe I could investigate some of these. Also things like massage. That could be partly a lot to do with the therapeutic touch or the interaction with the person doing it. And aromatherapy, which can involve massage sometimes, could also have that effect. Other forms of therapy that would fall under this broad intervention would be things like Reiki or reflexology, but these are really more, again, on the fringe because these are quite hard to explain from the conventional perspective and are perhaps more energy-based. Certainly Reiki is. So I would urge you to, certainly investigate some of these and focus on the positive aspects of mind-body therapies. So there are lots of these types of CAM therapies. Some of them might interest you. I hope, that you know a little bit more about them now. CAM is a very broad family of practices. So what I've tried to do really is to just simply give you a diverse, broad church on these, not describe each of them in gross detail. I'd be certainly happy to delve into any one of them or a few of them more deeply if you wanted. But what I was trying to do today is to give you a breadth. So some of them may help physical symptoms, some of them may help mental symptoms, but it is true that some of them may suffer from a lack of evidence base. That is certainly true. It is crucially important to consider quality and safety aspects of all aspects that I discussed, the materials, the practices, the people administering them. I would urge you that if you choose to use them, to just simply share that fact openly and don't be hesitant at all and engage openly with healthcare providers. I mean, at the end of the day, if you do decide to use CAM practices or not, it is your choice, but it is always best if it is done in a collaborative way. And in that case, I'd ask you, or I'd urge you to see them as integrative or complementary alongside, not alternative, not other. I did tell you earlier that we need to know more about CAM in Sjögren's, and I would exhort very much that you would engage with our research survey that will be submitted to you after this to learn more about your perceptions, beliefs and uses of CAM in Sjögren's. So I'll stop there and hand back to you, Joan. Thank you very much.
I'll give you a wee break there so you can have a catch your breath, and I'm just going to ask Michelle and Niamh to come back for a second. We had some comments just before James started around IVIG, if you'd like to speak to them.
Yeah, so I was following that kind of thread and it's really, really interesting. And firstly, so sorry to hear that people have, been having really severe symptoms, and, a great, I suppose, question about IVIG, and Lynn mentioned that she gets an infusion that is actually an IVIG. So that is a brand of that. So I think a couple of people were commenting that it's kind of difficult to sort of get a hold of. And I suppose just the reasons for that are, I think someone had mentioned it's expensive, and that's definitely true, but the evidence base for its use is not brilliant either. So that makes people prescribers and consultants maybe a little bit more cautious, because there isn't a lot of evidence to say that it's very effective. Now, that doesn't mean that it isn't, it just means there isn't a lot of evidence there. And also, some folks find they get an awful lot of side effects from it. So it is that balance between, is it, do we know, or are we confident that it's going to do more good than harm? And it probably comes down to a little bit. Someone else asked about, can it be used with a medicine called Cellcept? So that's the brand name for a medicine called mycophenolate mofetil, which is quite a mouthful. But it can technically be used with IVIG, and in some cases it can. I'm not sure, Niamh might know a bit more, but I've never seen it used for Sjögrens, the two used together. And it would be considered maybe sort of, kind of a very strong treatment, if that makes sense. So it will be right at the end, I suppose, right at the upper end of treatment in terms of the impact that it would have on the body, because Cellcept or mycophenolate mofetil is a strong immunosuppressant that would have originally normally been associated with, transplants and things like that. So that's why it was developed, but obviously has a role then in, immunomodulated inflammatory conditions. So, and I think Lynn had said, yeah, definitely check with neurologists, definitely the best step to take there. So, that was kind of just, that might be a little bit of the reason around why it's hard to get IVIG prescribed, because it's not got a ton of evidence base behind it. It has a lot of side effects for some people, not for everybody. But it definitely is worth having that conversation. And I suppose it links back to the fact that it's so important for us to try and understand what people need research to be done on. If we can sort of categorize that and then group it and then have some evidence for what the evidence needs are, it'll kind of help us, and not just us, but other groups working around the world to try to encourage a focus on these things, because then if they aren't researched, then we don't know, and there's no evidence, and that kind of cycle continues. So I hope that is helpful on that.
I might just add in, Michelle, as well, just to comment on that for the IVIG. I guess just also, as Michelle had said, and it was mentioned in the comments about the expense, that comes really from it being a scarce resource globally. So it's produced from blood, and it's a really complex process to manufacture it. So there is limited supply. So that's another reason why the evidence behind it is so important before people take the step to prescribe it. And usually they'll try and explore all other treatments before getting to it. So last year there was a national guideline published on IVIG use in different neurological conditions. Now, Sjögren neuropathy is mentioned in there as potential therapy, but it's not one of the main ones that automatically gets covered. So it does mention that it has to be a multidisciplinary team approach, and obviously some other things considered beforehand.
But it's definitely worth, and I think that's the strength of this community, is people who have had the experience, maybe sharing how they got that access, or what it was. And then Eileen had asked there about the evidence on stem cell treatment. So that's an emerging area. We were actually talking, Deirdre, Joan and I, about it last week, and Grainne had actually flagged it to us, and it's definitely an emerging area. As with all stem cell treatment, it's important to think about how it's administered, because it's been a topic of conversation for a long time that stem cells would maybe kind of cure everything. And I know there was a lot of questions around the ethical side of stem cells, which has now been addressed to a degree, but I'd say keep an eye on it. It's one of those things, those treatments that has had many kind of false dawns, and works well in small trials and then maybe doesn't scale up so well. So I would say, as yet, the evidence is not there to support its commonplace use. It's more in a research kind of space at the moment, but do keep an eye on it, because that could change going forwards as the evidence comes out from those initial trials that do look promising. But again, I'm always kind of a little bit afraid of the headlines that it's sorted, because more often than not it's not quite as simple as the headline suggests. So I'd say definitely keep an eye on it, but it's not there yet. That's okay.
Giving James a break, I'm going to ask him to come back. And there's a lot of interesting questions in the chat box. And I just probably go with one of the first ones from an evidence-based perspective. Have you found anything around complementary therapies that would help IBS?
That's an interesting question. Yes. There are a couple of studies that suggest certain herbal combination therapies have a potential benefit in IBS, but they wouldn't necessarily be ones that are available in an Irish context, unfortunately. So the product available in, I think it's Germany, that did show some evidence base in a well-designed trial. There aren't that many well-designed trials in IBS apart from, so the natural product peppermint, certainly depending on the nature of IBS. So IBS is very heterogeneous. Some people have more diarrhea predominant IBS, some people have more constipation predominant. So it depends on the person and what the symptomatology is. But certainly things like peppermint is very much a natural product. You can view peppermint in the form of a tea, as a food almost, or you can obtain a fully, so as an example of a licensed medicinal product, you can buy Calpermin capsules, which are simply peppermint oil enteric coated capsules, and that is the full status of a medicine. So, and that is shown in trials benefit for the spasm that is associated with IBS in certain groups of patients. But it is a heterogeneous condition. It's also been investigated in other forms of CAM, more manipulative types, and acupuncture, for example, but the evidence base, in my understanding, isn't as strong. So yeah, it can often...
That's fantastic. Sorry, just because I want to get through a few more of them, well, because people are starting to drop off now. We did have a comment, and I wonder, can you speak to it, around, for Sjögren's patients, that CAM can also give people hope, and you know that there's always something else coming down the line. What do you think about that?
I think that's very fair. I think it's a good point. Certainly, CAM is a very diverse church, and some forms of CAM, certainly, if they haven't been studied enough, so we simply don't know enough. But if you can be, if you can be happy that they're at least been administered in a way that is safe, then that is certainly the way I would be most concerned about. So if somebody anecdotally discovers a form of CAM that helps them, then I would say great, providing it's open and disclosed and discussed it, and therefore anything that might have been an issue has been picked up at the beginning. The worry about some aspects of CAM is that people often abandon conventional practices for various reasons, and understandably. But, I would say, please don't do that. Please have an open discussion around it. And if you find that it benefits you, then that's great, and yeah, absolutely. Some of them certainly would give hope, and they're not, not everything will suit everybody. Like, I know my imagery conversation didn't sit well with everybody, and that's an example of that, Yeah. So some people can find a benefit, some people can't. So certainly finding what suits you and investigating that is worth doing. But I would broadly agree with the sentiment that they can give hope, absolutely. They just need to be studied more.
Yeah, that came through as well. There were some suggestions that we need to have an evidence-based and definitely take the same rigorous approach that we do to traditional medicines, or the scientific approach to some of the new CAM stuff that's coming through. We did have a question around magnesium for systemic pain, specifically floating.
Okay, specifically floating, I can't answer that specifically. I don't know enough about that, to be honest with you, but there is evidence that magnesium is beneficial in certain painful conditions. So for example, in the context of migraine, magnesium supplements do have some evidence base with regard to that, along with some concomitantly administered herbals. In specifically that particular type of pain mentioned, I'm not aware of any study in that regard, but there is some evidence base behind magnesium supplements in certain forms of pain, yes.
You didn't come across anything regarding magnesium and brain fog when you were going through your studies there? Not
brain fog, no.
No, that's just another magnesium related question. There was a lot of chat around the omega-3s. Yeah. And actually I think it's kind of, it's a bit divisive. Some people have been told to take it, other people are not, because it can dry out the eyes, it can have anti-inflammatory effects, and about the ratios.
That's true.
Thoughts on that?
It's a very good point. And a lot of the discussions and thoughts about omega-3s and omega-6s go back to how we evolved. So we evolved, if you want, in a sort of Paleolithic diet whereby we were taking roughly equal quantities of omega-3 and 6 in our diets naturally. But because of our modern diets, that's not the case. And now it's estimated we take hugely too much omega-6 type balance as opposed to omega-3. So we're not getting enough in. And that's, I suppose, the problem. Then that has led to questions about how much and what type of diet and what dose you have. If you have a plant-based diet and you take, for example, 2 oily fish meals a week, that's the recommendation that you should, then you're probably getting a decent intake. We can produce omega-3s to a very small extent in our bodies, but it's not a very efficient conversion. So if you choose to take omega-3s, then you need to, it brings up a question about how much, where you get them from, what their quality is. There's so many questions around them. And I understand then that would lead to people being perhaps a little more cautious. Now, there are some products that are licensed, medicinal products that are omega-3 based, but they're not licensed specifically for the treatment of Sjögren's. They're licensed for various cardiovascular and other purposes. And their doses range up to gram quantities. In the context of recommendations for intake, if you choose to supplement yourself, I wouldn't recommend that you took any more than 2 grams. Typically 1 to 2 grams of omega-3 supplementation is advisable as the maximum, and that you should be ensuring that your product is only omega-3, it doesn't have omega-6 and 9s, and that it doesn't have vitamins A and D, because then you can be overdosing in those. So you need to be careful about the product you're taking. Is it good quality? It's omega-3 only. And to be honest, unless you are a vegan or vegetarian, that it is of a fish origin, because they're the ones that have been studied. Omega-3s are rare in plants. They occur in flax seed, for example, or linseed, but the actual exact nature of them is a bit different. So we can't directly translate the evidence for plant-based omega-3 studies for plant-based omega-3s into our recommendation, because we don't have it. Most of our studies are based on studies on fish-derived omega-3s. So hopefully that answered a few of the questions that were popping up about omega-3s.
Did. And actually, as you were talking about diet and Sjögren's being an autoimmune condition, would an anti-inflammatory diet then be helpful there, or was there any evidence?
There is some evidence to support that, yes. And that's why, and in some cases, you'll see the notion of using anti-inflammatory spices in the diet. So particularly, for example, the use of spices like ginger, turmeric, that's seen in traditional systems of medicine like Ayurveda and Persian medicine, have got more traction now. So that's interesting. But of course, that's incorporating them into the diet as opposed to taking active supplements. So there does seem to be some evidence around the anti-inflammatory diet, yes. But it's complex, and obviously there's lots of different components in a good diet. I would just be careful not to, to follow any advice that's talking about extreme or unusual diets that could lead to deficiencies. So, if you are considering dietary manipulation that's significant, it would be best to do it under the care of a nutritionist.
And actually, we have an interesting one around sleep. Is there anything kind of in the CAM catalogue that would be good to help poor quality sleep, or is there any evidence?
That's very interesting. I have a particular interest in sleep. There certainly is, but there's lots of practical advice around sleep that you should take into account that's about sleep quality, that isn't necessarily about consuming things. And maybe most people know these things, but simple things like not eating too late in the evening, restricting caffeine, swapping decaffeinated drinks, and avoiding alcohol or some other stimulants late in the evening, avoiding noise, blue noise. You can get filters for your phones. Sleep hygiene and sleep quality is hugely important, never mind consuming things. But there are some herbal supplements with evidence base, a certain amount, not huge, but a certain amount in sleep benefit, but they wouldn't be studied in the long term. So obviously if somebody has sleep problems, they often have them chronically. So there are some THMPs, remember those traditional herbal medicinal products that are used traditionally for sleep, and they would be, for example, valerian-based products, but they're not suitable for everyone. You can't take them if you're pregnant. There are other certain reasons why you can't take them, so you would need to check with your pharmacist. But there is some evidence base behind particularly valerian as an improvement of sleep quality in the short to medium term. But the concern is long-term use, we don't know as much, and question marks around liver toxicity raise their head in taking these things long-term. So some evidence base, but not long-term and not absolute without a discussion about whatever else you're taking.
Perfect. I'm just going to ask if anybody has a question in our audience. So, if you want to raise your hand and turn on your microphone, is there anything you'd like to discuss with James or Niamh or Michelle? Because there's a lot of stuff in the chat box, but if anybody has anything specifically they'd like to have a chat about. I think we might be getting to the end of people's oh, Nicola Davies has your hand up. Do you want to turn on your microphone there, Nicola?
Sorry. Yeah, thank you for all the information. It's really informative, but I have been concerned in the past about conventional medicine and the side effects, but I found I have tried various things like acupuncture and supplements, especially for the immune system, because obviously having Sjögren's, the immune system's really affected. But I found that these supplements aren't good because we need to suppress our immune system. So so that, you know, I'm finding that difficult, sort of balancing sort of conventional medicine with alternative. But what you've said has really opened my eyes, especially with the sort of like just thinking about the lemon. That was very good.
Mm-hmm.
But also, do you think that the vitamins from our foods now isn't as good as it used to be? I mean, that's concerning for me because I can't afford organic food. So that is one thing I'm sort of concerned about.
Sure, thank you very much, Nicola, and I can totally empathise with everything you're saying there. Certainly, the aspect of vitamins and supplements in food is something that we wouldn't have seen in the past. So there is an increase in supplementation in a lot of the basic staple foods that we would consume now that wouldn't have been the case in the past. And that would be to alleviate conditions that would we think of as the past, like scurvy and rickets. So for example, flour, cereals, milks, they're often now supplemented. So I would see that as a positive thing, as opposed to actually to the past. Also, there's a lot of interest now in different diets. So for example, vegan diets are increasing, and people with vegan diets often have very positive health outcomes, but they can sometimes be deficient in certain micronutrients. So they need to be careful. Now, they're usually very well educated around that, but they do need to be careful around it. With regard to you know, your points about cost, I totally agree. There are a lot now, there's a whole industry of organic supplements out there as well in the herbal medicines industry, which has some positive connotations, but also serious connotations about cost. I think we all have to acknowledge organic food is significantly more expensive. But yeah, hopefully that answered your question, or at least acknowledged some of what you're saying.
Yeah, lovely. Thank you, James. That's good.
Monica, you have your hand up there. Would you like to turn on your microphone?
Now you can see me too. Niamh, I think this is a question for you. We are told we're taking new medicines, and I'm a hypersensitive person to everything. And they say the side effects will wear off with time. But if the side effects wear off, what about the efficacy of the medicine? Does that wear off as well? Is the body selective? Can it work out what it's supposed to react to and not react to? It has me a bit confused.
Hi, Monica. Thanks for reading that question. Yeah, I think when it comes to the active ingredient or the active treatment of a medication, in most cases it would still continue to work. So sometimes the side effects that are experienced at the beginning are just, it might be adjusting to the excipients. It could be like a gastrointestinal reaction. So just getting used to having to swallow it if it's an oral medication. But just because the side effects have worn off, it doesn't necessarily mean that the actual activity of the drug has worn off. In most cases, that wouldn't be the case. Now, there are some medications where you might be monitoring for, like, to tailor a dose. So to say if a dose is slightly too high or slightly too low, I'm thinking of maybe the levothyroxine, so the troxin, which would be a supplement for people that have underactive thyroid. And there might be some cases where people tailor according to the side effects that they're experiencing. But for others, this wouldn't be the case. So, I mean, if that person has particular concerns about the treatment wearing off, they could chat about it with their doctor, but it wouldn't necessarily be a sign that it's wearing off.
And can I jump in there, Monica? Just say as well exactly what Niamh said, but don't, always ask, because, don't be afraid if you start taking your medicine and you're like, I'm wondering, I hope this will wear off, or I'm not sure. Just phone your pharmacist or, your GP or whoever. Don't feel you have to wonder, because there's people there to help and they will be able to give you some advice. Because exactly as Niamh said, a lot of times, tummy upset or headaches or mild kind of reactions will wear off with time, but for others that's not the case, and for some they're more likely to occur after a period of time. So just check in, because we'll know, your pharmacist will know what's the case for the particular medicine you're on. And particularly I would have known my patients with Sjögren's very well when I was practicing, because I would see them a lot and I would be delighted to would know the medicines that they were using and everything like that. So I think Niamh's advice to try to go to one pharmacy, try and build up a relationship with one pharmacist who will know and be able to help you, as you feel comfortable, is a really good idea. And, the other thing I'd say is, as James said, don't be afraid to tell us you're taking something you might think we might judge, or we might say, oh goodness, why would you take that? Or that's, a silly thing to do. It's much easier to know, because some of those side effects that Niamh mentioned might be being worsened by a different medicine, but if we don't know, we can't help. So just do ask is always my advice.
Well, GI seems to be the problem with most medications. Doesn't really, even with omega-3, I think. Yeah, okay, thank you.
Perfect. Vicky Fox, you have your hand up there. Do you want to unmute yourself?
Yeah, it's not a question, it's just two comments I would like to make. One was someone asked about nutrients, vitamin contents of vegetables and fruit. I mean, there's well proven that the nutrient contents of those nowadays have really gone down a lot. And if one looks into how these are nowadays grown, I don't think that's actually necessarily surprising. And I think we also need to watch out on the changes in more modern vegetable fruit culture, looking, for example, in hydroculture. So how do they make sure that these plants get the right mix of nutrients to actually then contain these? There's just one comment. So there's definitely has been a change in that one. The other comment I would like to make, and just to the nutrient content. So I'm partly involved in animal feed. And it's very interesting. Just for example, you have to adopt your feed composition, just whether you get, for example, soya from Brazil or soya from the US or Canada. They actually have different nutrient profiles, so you actually have to adapt your feed composition to make up for it, just as a comment. And the other thing was the thing about anti-inflammatory nutrition. And my view is, it's not, if you look into anti-inflammatory nutrition, it's not about adding things to lower your inflammatory symptoms. In my opinion, it's just finding those feed components which actually trigger you, and then particularly looking into, for example, dairy, sugar, pork can be one for some people. So for me, it's less about adding, it's more about taking things away. It's just my comments. Thank you.
Thank you so much for coming on and chatting to us, Vicky. Therese, Kelly, you have your hand up.
Hi, thank you very much for found it all very informative. Just on a positive note, having spent about, I suppose, 9 or 10 years waiting for a diagnosis, it's great to have a diagnosis. And I was started on Plaquenil first, and then after a few months I had serious joint issues, and then I'm on the minimum methotrexate and the Plaquenil and find it absolutely great now. Lead a very active life, and I find the resistance training once a week keeps the joints, keeps all the muscles strong to support the joints, and that has been a marvelous help. I'm much stronger altogether than I was, and I do think keeping active, walking and resistance training has been a complete game changer with the rheumatoid arthritis that I have, along with the Sjögrens. But I would say, if somebody asked me, I'd say I'm very healthy, and living with Sjögrens can still be a very full, active life, and I feel very well. Have bits of flare-ups, but knowing what the symptoms, and I had been very sick and had very bad, different. I mean, it was one thing after another. You just wouldn't know what was going on with all the different symptoms. But find it's marvelous now with the medication and the physiotherapy resistance training program that I do every week, and try and keep a bit of exercise going is the most important. So thank you very much for today.
Thank you for coming on. And actually your comments are a lot of what we got back from our last survey. So we asked participants and those who live with Sjögrens what advice they would give to someone who's been newly diagnosed. And a lot of it was around obviously advocacy, being your own advocate, but a lot of it was, to be active to the level that you can be, because obviously that you can tip things the other way, but to be as active to the level that you can be. And obviously James spoke to that as well, around the benefits of being active just normally, and obviously then what it can do for those with Sjögrens. I'm just going to, in the interest of time, say that big thank you to our guest panelists today, Grainne, Tynan, Deirdre Collins, Michelle Flood, Niamh Dillon, and James Barlow. Thank you so much for coming today and for chatting to the community and for having such great discussions.